of brilliant minds and pioneering spirits. Please kindly greet the person behind you, to your left and to your right, and tell them you're looking better than the last time I saw you. A special welcome to the Tiger Brands Foundation, our main sponsor, as well as our colleagues from the Department of Health. A warm welcome to our online delegates, the delegates in the auditorium, as well as our exhibitors. Today we come together to explore, discuss, and celebrate the latest advancements under the theme Dietetics with Dignity. This theme underscores the importance of approaching nutrition and dietetics with a focus on respect, compassion, and a deep commitment to enhancing the quality of life for all individuals. This symposium promises to be an exciting journey to the frontiers of dietetics, featuring a series of presentations as we delve into how we can integrate dignity into our practices, ensuring that our work in dietetics not only improves health and outcomes, but also respects the inherent worth of every person. We are thrilled to have such a diverse and esteemed group of participants, including leading experts, emerging researchers, and dedicated professionals, all united by our shared passion for scientific discovery and the betterment of human health. We are grateful for the support of the Tiger Brands Foundation, whose contributions have made invaluable in making this event possible. As we embark on this intellectual adventure, I encourage everyone to engage actively, ask questions, share insights, and take full advantage of the opportunities to connect with peers. Let us make the most of this symposium, fostering an environment of curiosity, respect, and inspiration. With Dietetics with Dignity as our guiding principle, let us explore how our research and practice can elevate the standards of care and support we provide, always mindful of the impact our work has on individuals and communities. Before we begin, a few housekeeping notes. To the delegates inside the auditorium, the attendance register you signed at the registration table this morning will be used to award your CEUs for the first session. 2 additional attendance registers will be circulated throughout the symposium. Please ensure those to update your CEUs for the rest of the day. There are bathrooms down the passage of the building as well as upstairs. If you need assistance locating a bathroom, just ask one of the young people dressed in red and they will kindly assist you. To our online delegates, we will observe your virtual presence to award the CEUs. You may also post comments and questions in the chat box throughout the CNE, and we will respond to those during the Q&A times. We hope that you will enjoy your day with us. Now, please put your hands together as we welcome your host, Dr. Lucia Meku, to the stage.
Good morning, ladies and gentlemen. A warm welcome to our department's annual CNE of 2024. It is a bit of a chilly morning, but I think the weather has actually worked in our favor today. I want to welcome all of our colleagues, our alumni, and a special welcome to all our guest presenters this morning. The CNE would not be possible without your presence. Let me also welcome all of our online delegates. Our new normal is that we are able nowadays to meet both face-to-face and virtually, and this affords us an opportunity again to be able to get in touch with those we haven't seen in a long time. I also want to welcome, I think they're all in the other venue, our medical representatives that are here today, and say thank you very much for supporting our CNE. Just as an introduction, the theme for today, Dietetics with Dignity, came out after our discussion with the Tiger Brands Foundation and preparation for this day. And I want to implore you today, in a world that is faced with a lot of uncertainty, to really own this theme for us. I think we are in a very precarious situation in the country currently. And a lot of us are sitting with anxieties and fears about what is going to happen. But I have an ethos to say it begins with me. And I want to encourage you to act with dignity, whether it is to your fellow colleague, whether it is to your patient, or whether it's a citizen in our day-to-day lives. Imagine what the world would be like if we all treat each other with respect and dignity. Welcome, enjoy yourself, interact with us. We're happy to have you here. Thank you.
Thank you, Dr. Meku, for your inspiring words. Ladies and gentlemen, I am pleased to introduce our esteemed guest, Mr. Cole Miller, a dedicated professional currently overseeing an organization that aims to enhance the support for family-based care, family strengthening, education, health, and advocacy programs across 25 countries in Africa. In his role, Cole is responsible for building a new team and ensuring business continuity during this transformative period. The initiative is crucial for better serving the needs of children and families throughout the region, aligning with our symposium's theme of dietetics with dignity. Please join me in welcoming Mr. Cole Miller from the Tiger Brands Foundation.
Thank you. Maybe just a correction. I think my office sent the wrong bio. We don't operate in 25 countries across Africa. We're only present in South Africa. That was a previous bio. It used to be that I had papers to remind me of what to say, and I knew exactly what to do. But now, in the modern era, you need to look at a screen on a screen, and hopefully it doesn't switch off while I'm speaking. So we'll see how this goes. Prof. Meko, ladies and gentlemen, distinguished guests, esteemed participants, it's my pleasure to be here today at the University of Free State's Continuing Nutrition Education Symposium. The Tiger Brands Foundation is very proud to be the anchor sponsor. And I'm greeting you this morning on behalf of Mr. Eugene Absalom, our director, who would have been here, but unfortunately due to health reasons couldn't join us. He sends his apologies and also his greetings to everybody. As we begin the symposium, we embark on a journey of exploration where we will delve into the intricacies of nutrition and its profound impact on our overall well-being. And in an era of constant innovation and technological advancement, it seems very good to me that the organizers have chosen the topic of dietetics with dignity. As we know, nutrition doesn't only affect our physical health, but also our mental and emotional well-being. At the Tiger Brands Foundation, dignity is a key pillar of the work that we do. We believe you must see the human beings that you're working with. And I'll talk a little bit more later about how we see the human beings that we call our beneficiaries. This aspect of dignity will become more important to remember in the context of topics like artificial intelligence, cognitive development, calcium dilemmas. I didn't know calcium could have a dilemma. Is it a self-aware nutrient? Shrinking fatty livers, note to self, and driving athletes to achieve more, and the treatment of severe acute malnutrition. All of these topics are very academic and very complex in nature, and all of them will be addressed today. And because they're academic and complex in nature, we really run the risk of seeing the problem and not the person. This is a problem we face as the Tiger Brands Foundation as well. We've decided to tackle a very large and a very complex problem, that of nutrition of learners in school. And it's very easy for us to slip into seeing our solutions and not seeing the young people we work with. And it's a key component of our work if we're going to be successful. We want to leave those young people with a good impression and good memories of nutrition. Right? I don't know, for those of you that still have grandparents and they describe getting a spoon of cod oil. Maybe some of us can remember that, right? Might have been a very healthy intervention, but it didn't leave a good impression of nutrition. And that's where we have to be focusing. I'd like to express my heartfelt gratitude to the organizers and the sponsors of this event. These things don't come together by themselves. It's hard work. We do several ourselves, Prof. So we understand. So well done to you and your team. Thank you very much. And if I may just also thank Dima and Morena, my team. They're a man down, but they're manfully doing their job. Thank you very much for your work. Together, let us ignite the flame of knowledge, embrace the power of collaboration, and work towards a future where optimal nutrition and dignity is available for all. To end, I encourage us today to engage in thoughtful discussions and exchange perspectives. Let us remember the far-reaching implications of our work. Our findings has the power influence public policy, guide dietary recommendations, and ultimately shape the future of nutrition, but only if we see the people we are working with. I thank you.
Thank you very much, Carl, for your inspiring words. We begin the presentations with the SAGE's Best Oral Prize winners at the International Hepatobiliary Association, IHBPA, 2024 Congress. We would like to thank SASPN for the presentations of Mrs. Mika Price and Dr. Francisca. It is my pleasure to introduce our esteemed guest speakers, a father-daughter duo, Dr. Francisca, a specialist surgeon, and Mika Price, a highly skilled dietitian dedicated to helping individuals achieve optimal health through personalized nutrition and dietetic interventions. With a strong educational foundation, Mika has developed a comprehensive approach to addressing various nutrition and health-related issues. The holistic approach ensures that clients receive tailored guidance to improve their overall health and well-being. Please welcome Mrs. Mika Price and her father, Dr. Francisca, all the way from Boksburg.
Very much. Good evening, everyone, and thank you very much to SASPN for the opportunity to present tonight. Thank you, Engela, for the introductions and for chairing our presentation tonight. Before we get started, we would just like to state that both Dr. Skitz and I have no affiliations to declare. Tonight, we will be discussing a topic that both Dr. Skitz and myself are very, very passionate about. We'll be addressing the decrease in liver volume and visceral adiposity in patients with MASLD, or metabolic dysfunction associated steatotic liver disease, formerly known as NAFLD, using a preoperative very low-calorie diet. These terms are a mouthful, so if I stumble over them a couple of times, I do apologize, but most likely for the remainder of the presentation, I will be referring to it as MASLD and a VLCD. The images on the right will be addressed in a little bit more detail later on in the slides, and you will most likely see them several times, or you will see them several times throughout the slide. But I would just like, throughout the presentation, but I would just like to point out that the image at the top is a fatty liver that the surgeon is trying to lift with the retractor to get access to the esophagogastric or the EG junction. The second image at the bottom is a smaller liver with little to no fat that can easily be retracted to access the EG junction. I don't think you need to be a doctor or a surgeon to visibly see the difference between these two livers, and we'll be addressing the surgical implications of operating on a patient with an enlarged fatty liver. Our agenda for this evening is as follows. So I will be starting off with a background into non-alcoholic fatty liver disease, as to what it is, what it entails, and the pathogenesis thereof. I'll also be addressing the name change from NAFLD to MASLD and the change in diagnostic criteria. Dr. Skitzer will then come in and discuss the surgery of the foregut in a patient with hepatomegaly. He will explain it further, but the foregut is comprised of the distal end of the esophagus, the stomach, and the portion of the duodenum, particularly D1 and D2. I will then discuss implementation of a preoperative very low-calorie diet, or VLCD, and highlight a recent study that we've completed, as well as looking at some case studies. And lastly, I'll be addressing the importance of the role of the dietitian in the surgical team. There may be some points during the presentation that both Dr. Skitter and I repeat, but it's merely to reiterate the importance thereof or the significance thereof. Let's start off with discussing what is NAFLD. I'm sure it's a diagnosis that we've all come across. NAFLD is a diagnosis that was developed in the 19th century by Ludwig et al. As a hepatic condition similar to alcoholic hepatitis, but presenting in patients without a history of significant alcohol consumption. It's a generally benign condition that results in an enlarged fatty liver or hepatomegaly. The presentation of NAFLD involves various factors, including obesity, insulin resistance, genetics, and lifestyle choices. Hence the reason it's closely linked to excess body weight rather than alcohol use. Unlike many other health conditions, persons with NAFLD are often asymptomatic, meaning that they don't experience any notable symptoms, especially during the early stages, and it quietly progresses to non-alcoholic steatohepatitis or NASH without showing any initial signs, leading to severe complications such as liver cirrhosis, liver failure, or even hepatocellular carcinoma. A healthy liver contains little to no fat, whereas patients with NAFLD present with more than 5% of accumulation of fat in their hepatocytes. As a result of the worldwide obesity epidemic, there's been an increase in the prevalence of NAFLD, and NAFLD is seen in more than 80% of obese persons. It's long been documented that NAFLD is associated with metabolic syndrome and has become known as the hepatic manifestation of metabolic syndrome. Metabolic syndrome is associated with chronic low-grade inflammation and increased oxidative stress in the body. And inflammation plays a significant role in the progression of NAFLD to more severe forms of such as NASH, fibrosis, and cirrhosis. NAFLD and metabolic syndrome have a bidirectional relationship, meaning that each condition can worsen the other. For example, NAFLD can exacerbate insulin resistance and dyslipidemia, further contributing to the development and progression of metabolic syndrome, and conversely, metabolic syndrome can worsen liver inflammation and fibrosis in individuals with NAFLD. However, there are some anomalies that do occur, and we've come across them in our practice. We've come across patients with lean NAFLD, which are patients who have a normal BMI but present with this very large fatty liver. Although the mechanism behind lean NAFLD is not quite fully understood, I will mention possible causes a little bit later on in the presentation. And we've also come across persons who are obese, yet present almost unexpectedly with a smaller liver volume. Essentially, not all obese individuals have the same degree of adipose tissue and distribution or metabolic health, which can then influence the risk of NAFLD. There's also genetic factors to consider, but for the most part, overnutrition results in the rise of adipose deposits and subsequent accumulation of ectopic fat. I'm going to take you back to our biochemistry days when we discussed the pathogenesis of NAFLD. So it's important to remember that the liver is a metabolic organ that regulates physiological and biochemical processes such as energy and fat metabolism. Specifically looking at fat metabolism, the liver is involved in lipogenesis and lipolysis. So de novo lipogenesis is the process of synthesizing fatty acids from excess carbohydrates, which are stored as triglycerides in the adipose tissue or in the liver itself. Lipolysis involves the breakdown of the triglycerides into fatty acids and glycerol, which can then be used for excess energy and transported to other tissues for utilization. But excess calorie intake leads to the accumulation of excess triglycerides in the hepatocytes, and these triglycerides are then stored as little fat droplets, leading to hepatic steatosis. Decreased energy expenditure and sedentary lifestyles exacerbates the energy intake and the energy expenditure balance, and even a slight weight gain of between 3 to 5 kilos can actually predict NAFLD. Obesity-related insulin resistance is hallmarked by impaired triglyceride storage of fat cells, and this and increases peripheral lipolysis by decreasing the delivery of free fatty acids in the liver, thereby resulting in these increased amounts of free fatty acids that are circulating. Insulin resistance also upregulates de novo lipogenesis in the hepatocytes, and the excess circulating free fatty acids results in the delivery of these free fatty acids to non-adipose tissue, such as the liver, resulting in hepatic steatosis. So why the name change? Recently, there have been concerns with regards to the accuracy of the term NAFLD, as the words non-alcoholic actually inaccurately describe the nature of the condition, and the term fatty is often considered stigmatizing. In fact, it's not only the name that has changed, but the diagnostic criteria of NAFLD has also changed, as the term NAFLD is actually a diagnosis of exclusion rather than inclusion. And these concerns prompted research into adjusting the nomenclature to include persons who also have a fatty liver, regardless of their alcohol intake. So hence, in 2023, Ranella et al. Embarked on conducting a Delphi study with academic professionals around the world, as well as patient advocacy groups, to reach a consensus in the change in the nomenclature and the diagnosis of NAFLD. The results indicated an overall support for steatotic liver disease, or SLD, becoming the umbrella term for the spectrum of hepatic steatosis, with MASLD replacing NAFLD and metabolic dysfunction associated steatohepatitis, or MASH, replacing NASH. By changing the diagnosis to include the terms metabolic dysfunction associated, the focus then shifts to the broader metabolic factors that contribute to the disease rather than just the alcohol consumption. There's also a separate diagnosis, which is metabolic associated liver disease, all very confusing, or called MET-ALD, which will be used for patients that present with NAFLD but who consume more than the recommended amounts of alcohol a day. So the recommended amounts for females is between 20 and 50 grams of alcohol a day, whereas for males it's between 30 to 60 grams a day. The definition of a standard drink varies from country to country, but in South Africa, a standard drink of alcohol contains 12 grams of alcohol. So this equates to about 2 to 4 drinks a day for a female and 3 to 5 drinks for a male. Just to kind of put this into perspective, the average restaurant serves 150 ml of wine, which is 1.5 standard drinks. So if we have a look at steatotic liver disease, or SLD, which is the umbrella term, we then have MASLD, which progresses to MASH, and we have MET-ALD, as well as alcoholic liver disease. And then we also have specific etiology or cryptogenic SLD, or liver disease of unknown causes. The diagnosis of MASLD actually requires histological confirmation, but this is a risk-related procedure, a risk-related invasive procedure. So while a liver biopsy does remain the gold standard for diagnosing NAFLD and can provide valuable information for the disease management and the progression, there are risks involved, including bleeding and infection. So a non-invasive liver ultrasound imaging can be used to diagnose hepatic steatosis, as well as to determine the total segmental hepatic volumes, which we will be discussing a little bit later on in the presentation. As mentioned earlier, along with the change in nomenclature, diagnostic criteria have also changed, which also suggests to include hepatic steatosis with at least one cardiometabolic risk factor, so such as either BMI, increased waist circumference, hypertension, elevated triglycerides, or decreased HDL levels. So here I'm then going to go through the diagnostic flow diagram with hepatic steatosis confirmed by either imaging or biopsy. We then need to ask if the patient is presenting with any cardiometabolic risk factors, and if yes, are there any other causes of steatosis which will result in a diagnosis of either MASLD or MET-ALD? If the patient doesn't meet the cardiometabolic criteria, we end up with a diagnosis of cryptogenic or the specific etiology SLD. Looking deeper into the cardiometabolic criteria, the patient needs to meet at least one, like I mentioned earlier. So they either need to have a BMI over 25 or an increased waist circumference. They need to have increased elevated fasting glucose tests or HbA1c, or have a diagnosis of type 2 diabetes, or be on medication for the management of type 2 diabetes, either have an elevated blood pressure or elevated triglycerides or decreased HDL levels. So this is really where the example of lean NAFLD comes in. The patient may present with hepatic steatosis but have a normal BMI, yet have elevated triglycerides. So this indicates that even in the absence of obesity, the role of diet and macronutrient intake are centered to the onset and the progression of NAFLD. I'm now just going to hand over to Dr. Skitzer, who will discuss the surgical implications of the patient with hepatomegaly.
Thank you, Mika. I hope everybody can hear me. Thanks for this nice overview. And Ingela, thank you for inviting me to give a little bit of the surgical background and the perspective of how we as surgeons see the big problem of hepatic steatosis. While you read through the slide, I'm going to stay with the slide a little bit. I want to start off by making a statement and to highlight the fact that the dietitian must play an important role in the perioperative treatment of any patient to undergo upper GIT surgery, especially hiatus hernia repair, like we're going to focus on today, or the redo. No hiatus hernia repair is a surgical emergency. The only emergencies that do exist is when you get a roll-type hernia, which is a special indication on its own with the incarcerated roll-type hernia, or in a patient who had a preoperative paraesophageal hernia with incarceration. So there's no reason why the dietitian should not be involved. And you will see, hopefully at the end of this slide presentation, how important the preoperative treatment of these patients are. Now we're talking about the surgery of the foregut. Just to give you an example of what the foregut really is, during the formation of hiatus hernia, the intra-abdominal esophagus moves up into the chest cavity. So it includes the lower part of the esophagus, which is about 4 or 5 centimeters. It includes the stomach, the pylorus, and the first part of the duodenum. You can see on that little picture on the right-hand side, we'll move over to it later on. Now, I started by saying it's technically challenging. All endoscopic surgery is technically challenging. The reason for that is we work in a space-related organ. The abdominal cavity is a closed cavity. It's not like a balloon which you can inflate with nitrogen and eventually get bigger and bigger and it will float away and it will burst. You cannot inflate the abdominal cavity more than what it can take. It's like a soccer ball or a rugby ball which is sutured together with leather pieces that suture together. So you can only inflate it to a certain maximum and then it stays there. So our biggest enemy in laparoscopic surgery is space. We need space. Space is our enemy, and the lack of space is our enemy. Space is our friend. What is occupying that space for us? If you look at the drawing on the right-hand side, the transpyloric plane, which unfortunately in this drawing is a little bit high because the pylorus is a bit lower for where that line is, but that's not important. We work in sections 1, 2, and 3. I'll get to that a little bit later. You can see that the liver occupies most of those areas. The left hypochondrium, the right hypochondrium, a little bit in the normal liver. Epigastrium is number 2. So the liver is one of the biggest enemies in working in the upper abdomen. The next one is visceral adiposity, and Miko is going to address both these subjects today, the steatotic liver and the visceral adiposity. Due to the lack of limited space, we as surgeons do have problems. We've got decreased visibility in that area. And I'll show you some photographs of it later on. It's more difficult to perform the difficult, intricate surgical tasks like suturing or knot tying. I very often explain to my patients that it's like operating inside the beer glass. But with the steatotic liver and the fatty omentum, it becomes like operating into the champagne flute. There's also increases in trauma, and we're going to show you something of that a little bit later. So how do we create space in the abdomen? If we talk about that, it's a rugby ball, it can't expand more. Certainly, we use CO2 to inflate the abdomen. Normally not above a pressure of about 12 to 15 millimeters of mercury. That is sufficient. We do not want it to be higher. It causes its own problems. It reduces the venous flow back to the heart. The cardiac output diminishes, and the drop in blood pressure. We also, when it's too low, you have got difficulty in visualizing the different organs. So the other thing that we use, this is number one. Number two is we place the patient in a deep, steep antitriangular position. That's head up, feet down. The patient is basically standing on the operating table with a base plate underneath him and strapped to the operating table. The reason for that is we use gravity for the momentum to fall back. Doesn't help for the liver because the liver is attached to the diaphragm, but it helps for the omentum and the colon, which is attached to the anterior part of the stomach and the transverse colon, for that heavy omentum to fall back into the lower abdominal cavity. And then lastly, we use a liver retraction. The liver retraction, we will speak about that, is a very dangerous instrument that can cause significant injuries. Can we have a next slide, please?
Sorry, I'm just moving over. Sorry. Don't know why it's not going forward. Let's try again. There we go.
Yeah, there we go. The next slide is a view. I just want to give you, because I'm not sure how many surgeons there are in the audience, but for the dietitians, I also urge you to attend a procedure, or maybe more than one. Ask your surgeon to explain to you the different steps, because you are going to be mostly number one person where they're going to phone with problems afterwards. Say, I can't swallow, I can't do this, I can't do that. So you're going to be able to explain to them what happens. So this view that we're looking at is from the transpyloric plane. So the first trocar, we use a 4-trocar technique. The first trocar is placed 2 centimeters above the umbilicus, right in the midline. So this is what we're looking at. The left photograph is a photograph of the left hypochondrium. So we see a very normal liver there, a nice sharp edge. It's small in volume. It's the length, and we will get to that, the length, the height, and the width of the liver. But what you can see there is the anterior surface of the stomach and part of the omentum. You can see on the left-hand side there's a falciform ligament, and all these structures are hanging down. Just remember that this abdomen is inflated. So in the deflated abdomen, the liver will lie right at the top against the diaphragm. But because there's now CO2 in the abdomen, it just falls down. The one on the left-hand side, on the right-hand side of the picture, is actually looking at segment 1, which is the part that the liver occupies most of the right hypochondrial space. What you can see there is the gallbladder at the bottom, where it makes like that U-shaped form. The ascending colon underneath it with the omentum, and you can just see the pylorus sticking out just underneath the liver. Next slide, please. I just want to talk a little bit about the anatomy of the liver. For our study purposes, and Mika will explain to you a little bit later, we look at segments 2 and 3 of the liver. That is the left of the falciform ligament. The reason for that is it's easy to measure with the ultrasonic device and to calculate the liver volume. And segments 4 and 5, the A and B segments, it's not really important for us because it's out of our visual field. It lies to the left of the inferior vena cava. I'll try to demonstrate it for you later in the video. That is the caudate lobe. The right lobe is not important and it doesn't affect our surgical field. Just one thing I want to draw your attention of, I don't know how familiar you are with the liver anatomy, but the liver is a very dynamic organ and it changes size and shape on a daily basis. The reason for that, there is a capsule that encapsulated the liver called Gleason capsule with the Gilsson, Gleason capsule. This is a very strong fibrogranular tissue layer of variable thickness and it encapsulates the liver. And it allows it to stretch and enlarge and shrink again. Just think about the marathon runner. After a marathon, he lost 2 kilograms in body weight due to dehydration. So that liver is now tiny, small, and shrunken. And once he's rehydrated a day later, that liver is back to normal volume. So the liver changes in size and shape. I'm sure most of you have seen a liver and felt the liver. A normal liver is a spongy, very strong type of organ. So you can push with a blunt instrument on the liver and you make a small indentation. And once the blood flow is restored, that indentation will disappear. However, and I think this is important, and this is why this talk is about, the steatotic liver is thin and fragile. It breaks easily and it bleeds easily. The cirrhotic liver on the other side is a tiny liver surrounded by this thick capsule of Gleason. It's like a piece of biltong with the sinew of the biltong. It's a tiny, rock-hard liver with a thick Gleason's capsule. Can we have the next slide, please? Now, we're talking about the surgical risk factors because for us as surgeons, we talk about the space. It's mostly related to the liver, which is enlarged, so it's space occupying, it's fragile, it bleeds easily, it's prone to traumatic injury with instrumentation. We all work with sharp instruments, and it makes it technically difficult because we need to work underneath the liver. Miko explained with the opening slide how easy it is to get access to the esophagogastric junction when the liver is small. The liver is also heavy. It's difficult to lift. I will show you some photos of a traumatic event and how difficult it is to lift this massive liver. Also, with that second point there, so the risk of traumatic injury is very real, and it can vary from, it's mostly intra-abdominal bleeding, which happens immediately. And it can vary from minimal bleeding to major bleeding, which makes it impossible to perform the surgery laparoscopically. Maybe you had to convert. Sometimes it can be even life-threatening. Can we have the next slide, please? The next slide is the one that Miko had up on the opening slide. You can clearly see that this patient got a steatotic liver. These little white dots, which you can see on the liver surface, is the fatty infiltration and the fatty deposits. It looks completely different from the one in the picture on the top right-hand side of the screen, which shows the ruby red color of a liver. You can see that the surgeon has inserted it's called a Nathanson retractor. It's a U-shaped instrument with a fairly sharp tip on that on the end. That is used to lift the liver. Because the liver is so heavy, this has been anchored to a pneumatic device that keeps it out of the way. The assistant surgeon is not using his hands to lift that liver. You can see that the assistant surgeon is trying to assist here by trying to lift the liver with his instrument at the top. The stomach is visible and the omentum on the other side. On the top hand side of the screen, which you can see, that's the 8th rib. That is the rib you can feel on your abdomen, on both sides of your rib cage. That's the 8th rib. The next slide, please. Now look what happened. The surgeon is trying to lift this liver, obviously. Surely this patient shouldn't have been on the OR table with the liver this big size, because we could work by utilizing a very low-calorie diet. We can work on the picture on the right-hand side. But clearly there's a big trauma happening now with a big laceration. That listening tissue that you can see in the laceration, that is Gleason's capsule. Right underneath it, you can see already bruising of the liver underneath it. And then you can see the big tear of the liver and some blood pooling on top of the stomach. Next slide, please. Now the surgeon has successfully managed to push that Matheson retractor right through the liver. So entry is below the liver, exit is above the liver, right through, in and out through the left lobe of the liver, with a pool of blood on top of the stomach, mesenterium. Clearly, this is now getting into a very difficult situation. Can we have the next slide, please? So, why should we decrease the liver volume by the laparoscopic? So I'm sure that should be very obvious for you by showing you just the pictures. Firstly, the liver is all related to the size of the liver. The enlarged liver is space occupying. It's fragile, it bleeds easily. It's prone to traumatic injury of the liver. It's difficult to lift. We have seen all those things in the photographs. And there's a high risk of traumatic injury and bleeding, like I said to you, with the risk factors there. Can we have the next slide, please? Now, this is the ideal situation where we wanted to be in. These are two photographs of two different patients who has been on our protocol. They have been operated on. That's not the same patient. On the left, you can see this is a very small liver. There's already a space between the liver and the stomach, which makes access to the EG junction very easily. The picture on the right-hand side actually shows where that same retractor is in place, and you can clearly see the difference between the two situations. That oval-shaped opening in the middle is the hiatus hernia that needs to be repaired. The lobe at the bottom is the caudate lobe. It is segment 4B, which is not important and doesn't affect us in the surgery. From the tip of the liver on the right-hand side, you see the triangular ligament that anchors the diaphragm to the liver. Thank you very much. With that, I hand it back to Miku for the rest of the presentation.
Thank you very much, Dr. Skitzer. Okay, so I will now be discussing what our preoperative protocol is, as well as how it has changed. Before I get started, I'd like to just briefly explain a study that we conducted in our surgical unit that we're in the process of publishing. So we had 48 participants that were scheduled to either go for a Nissen fundoplication or a redo Nissen fundoplication. The patients were referred to the dietitian 2 weeks prior to their surgery and were placed on a very low-calorie diet. The participants underwent an in-body assessment prior to the dietary intervention as well as post-dietary intervention, which was on the day of their surgery, to assess the changes in their body composition. They also underwent an abdominal sonar to measure the left hepatic lobe volume prior to the dietary intervention, and the sonar was repeated on the day of the surgery to measure the change in the left hepatic lobe volume. So the sonographer typically obtains the ultrasound images and measures the length, the width, and the height of the liver, of the left hepatic lobe, and they then calculates the volume using a formula for the volume of an ellipsoid. The surgeons can look at all four values, so they can look at the volume, the length of the left lobe, its width, as well as its height. How surgeons generally agree from their surgical experience that if the left hepatic lobe volume is under 250 mils, it's relatively easy, it's very easy to get access to the EG junction. If the left hepatic lobe volume is between 250 and 350 mils, it's relatively easy to access that EG junction. If it's between 350 and 400 mils, it starts to get a little bit difficult to access that EG junction. And a left hepatic lobe volume of 400 mils and over, it eventually becomes challenging to access that EG junction. So for the purpose of our study, we included participants with a left hepatic lobe volume of over 250 mils that were then referred to the dietitian for the preoperative VLCD. So when implementing a VLCD, so the literature indicates that a reduction in hepatic volume is attributed to weight loss in general, and it's not dependent on the specific diet, but the amount of proteins, carbohydrates, and fat in the preoperative nutritional plan plays an important role in reducing the hepatic volumes. So low-carb diets are commonly used in weight loss and decreased intrahepatic triglyceride levels. Therefore, they are often used in the management of NAFLD. There's no consensus with regards to the definition of what a VLCD is, but the most widespread strategy for weight loss prior to laparoscopic surgery is using a VLCD that is a meal replacement shake or a combination of food and a meal replacement shakes to restrict the calories actually between 600 and 800 calories a day. Our study participants were placed on either 800 or 1,000 calories a day, with the macronutrient distribution being 40% protein, 25% carbs, and 35% fats. We used our own discretion when it came to placing the patients on either an 800 or 1,000 calorie diet based on how compliant we thought the patient might be. An 800 calorie meal plan is a little bit more challenging to stick to than a 1,000 calorie meal plan. If we now move on to a case study. So we've got Mrs. R. So Mrs. R is a 35-year-old female that was scheduled for a Nissen fund application. Her initial left hepatic lobe volume prior to the surgery was 456 milliliters. She doesn't smoke. She drinks occasionally, only has 1 unit of alcohol at a social event and not really binge drinking. She doesn't have hypertension, hypercholesterolemia, or diabetes. If we have a look at her pre-intervention anthropometry, so her BMI was at 31, indicating a class 1 obesity. Her body fat percentage was 46.8%, where the suggested normal range is between 18 and 28%. Her body fat mass and muscle mass was 55.7 kilograms and 22.7 kilograms respectively. Her visceral fat score was 19, the normal range being between 1 and 9, and the fat around her abdomen specifically was 18.7 kilograms, and her waist circumference was 101.7 centimeters. We then placed her on an 800 calorie food-based meal plan for 2 weeks prior to her surgery. The meal plan included her recommended exchanges that she could choose daily, as well as a 7-day sample menu just to use as a suggestion. And on the day of the surgery, she self-reported her meal plan compliance to be between 75 to 100%. On all our participants, we tested baseline urine ketones, as well as urine ketones on the day of the surgery. She didn't have any urine ketones after being on the meal plan, and interestingly enough, only 13% of our participants had trace amounts of urine ketones after the 2 weeks VLCD. On the day of her surgery, her sonar was repeated to measure her change in liver volume, and her in-body assessment was also repeated. Her liver volume had actually almost halved. It was down to 225 milliliters on the day of the surgery. Her in-body results indicated a weight loss of 4.1 kilograms with a loss of 2.2 kilograms of body fat and 1.4 kilos of muscle mass. So we do expect there to be muscle mass when patients are on a VLCD, and extended periods of severe calorie restriction can lead to more significant muscle loss as the body seeks alternative sources for energy. Hence the reason we only recommended a 2-week VLCD. The mean muscle mass loss actually for all of our 48 participants was only 0.9 kilograms. Her visceral fat score was down by a point, and she lost about 1.4 kilos of fat around her tummy, and her waist circumference was down by 4.7 centimeters. So I really actually just want you to take a note here of her theater cutting time. Her theater cutting time was 22 minutes. So what are the consequences of MASLD? And what benefit are we actually bringing to the table by placing the patients on a VLCD? And I'd like to just spend some time on this slide. We recently had a patient who admitted to not being compliant on the meal plan. The patient was scheduled for a lap Nissen, and her left hepatic lobe volume prior to the surgery was 432 milliliters. So similar to Mrs. R in our case study, if you can remember, her initial liver volume was 456 milliliters. So due to the nature of the fatty liver, as Dr. Skitzer discussed earlier, she sustained a major liver injury during her surgery. And again, like he mentioned, you don't have to be a surgeon or a doctor to see the seriousness of an injury like this. The theatre cutting time in this case was 50 minutes, so more than double the theatre time of the patient of Mrs. R in our case study that we did previously. Typically, the patients after a lap Nissen, they usually only spend one night in hospital, but this particular patient ended up spending 3 nights in hospital, including 1 night in high care, and there was an intensivist that needed to be referred. She ended up having multiple physiotherapy sessions, needed additional pain management, and there was also increased post-operative investigative costs. So she needed an extra chest x-ray, abdominal x-ray, a sonar, and bloods. So the financial implications of this alone is immense, and it's potentially avoidable. Surgery such as anti-reflux surgery, like Dr. Skitzer mentioned, is not emergency surgery. And the benefit of waiting 2 weeks for the patient to be on a very low-calorie diet are evident, while keeping in mind the patient's compliance. Our concluding points are as follows. So a very low-calorie diet is a safe and effective way to decrease hepatic volume and visceral adiposity in patients undergoing laparoscopic upper GIT surgery. The effectiveness of these reductions suggests its potential for optimizing surgical outcomes, and the surgical advantage of a VLCD before laparoscopic surgery is evident. The effective 2 weeks is sufficient time to reduce the necessary changes to happen in terms of reducing the hepatomegaly and the visceral adiposity. And a reduction actually in body fat mass and waist circumference prior to the surgery can already indicate improvement in hepatomegaly. It was subjectively agreed by our surgeons that the larger the decrease in the left hepatic volume, the easier the access to the EG junction. And I think that was all really clear in the photos that we've shown earlier. So what has happened since our surgery, our study, what has transpired? So the participating surgeons have now changed their preoperative protocol to include the dietitian in every single patient undergoing a surgery of the foregut for implementation of a 2-week VLCD. There's no longer a need to do the preoperative measurement of the left hepatic lobe volume, so there's a bit of cost saving involved there, but this may balance out with the cost of the referral for the dietitian consultation. The theatre times have dramatically decreased with no adverse intraoperative complications being recorded. For the sake of interest, we just included one more study. This was a patient that we actually recently operated on, also Mrs. B, different Mrs. B to the previous one. She did not have a preoperative abdominal sonar. She had a preoperative weight of 126 kilos and a BMI of 42. We only had 10 days to do a preoperative meal plan just due to the scheduling of the surgery dates. And she was placed on a 1,000-calorie meal plan and she lost 3 kilos. So now you may ask, why is this patient on 1,000 calories when the previous case study was on 800 calories? Well, our study actually concluded that participants that were placed on a 1,000-calorie meal plan actually experienced a much larger percentage decrease in left hepatic lobe volume. So the patients that were on the 1,000-calorie meal plan experienced almost a 43% decrease in left hepatic lobe volume, whereas the patients on the 800-calorie meal plan experienced about 30%. Regardless, here in the image, you can see that despite her adipose tissue and her liver still showing signs of hepatic steatosis, it was easy enough for the surgeon to lift to get access to the hiatus. Looking at the role of the dietitian, so the role of the dietitian in the perioperative team is crucial in ensuring the optimal patient outcomes before, during, and after surgery. If the dietitian is included, and we all know that there are surgeons that don't include the dietitian as part of their surgical team, we are traditionally only included post-operatively. So it's essential to highlight to your surgeon the role that we can play pre-operatively in benefiting the patient and the surgeon alike, with the ultimate goal to be improving the outcomes and enhancing the patient's overall experience throughout the perioperative period. Again, as like Dr. mentioned, I would strongly recommend asking your surgeon if you can attend a surgical case in theatre to better get an understanding of the surgical process. We inevitably end up being the person that the patients contact first with regards to any concerns and questions. And if we've physically seen what's going on and we get a better understanding of it, it always makes it easier to address those questions. Lastly, so what's next? So currently there are no upper GIT ERAS guidelines in place. We do have ERAS guidelines for our bariatric surgery, and those guidelines do include a perioperative VLCD. But why is it not standard operating practice for all laparoscopic upper GIT surgery? So the goal is really to develop a standardized protocol for the pre-operative dietary management of these patients, which I'm currently embarking on in my PhD. Thank you very much.
Thank you very much, Mika and Dr. Schutte. Do we have any questions for our experts? Perhaps our online? No questions. Mika, Dr. Schutte, thank you so much. I think it's really amazing how you found that decreasing the weight of the liver can reduce the time spent on the surgery table and reduce the in-hospital costs. So that's really at the forefront of dietetics with dignity, giving the patients back their dignity, thinking about all aspects of their lives, just not only taking into consideration their surgery, but also considering their out of hospital, their hospital expenses, physio appointments, duration, laying open, having open surgery on a table. So thank you so much. We appreciate you.
Thank you very much.
Okay. Next up, ladies and gentlemen.
Sorry to interrupt. I do see that there is a question.
Yes.
Yeah.
Right. I just found one question from online. What is the aim of surgery in hepatomegaly or NAFLD?
I don't know. You can maybe elaborate a little bit. I don't know what you mean with the aim of surgery.
Yeah, this is a comment. I think the aim was it's for the innocent fund application. So it isn't for NAFLD or for the large liver. It was just to get the liver out of the way to be able to do the other surgeries, right, Mika?
That's exactly correct. Yeah. So the idea is to get that liver a little bit smaller so that the surgeon has got more space in the abdominal cavity. So like I said, we're doing it with all our upper GIT patients. So patients that are undergoing gallbladder removals, patients that are undergoing hiatus hernia repairs and anti-reflux procedures. I hope that answers the question.
Right, thank you so much, Mika and Dr. Schutte. We have a token of gratitude for you that we will send to you in the very near future.
Thank you so much.
Next, we have our esteemed speaker, who is Dr. Liska Robb, known fondly as our Minister of Micronutrients. Dr. Robb is a leading expert in the field of dietetics with a particular focus on maternal and child health. She holds a PhD in dietetics and has dedicated her career to advancing our understanding of micronutrients and their crucial role in promoting health and well-being. Our ongoing research in maternal and child health has been groundbreaking, providing invaluable insights that inform the best practices and policies.
In addition to her expertise in nutrition, she is well versed in ethics and the use of artificial intelligence in dietetics practice. Her work in these areas is shaping the future of dietetics, ensuring that technological advancements are integrated ethically and effectively to enhance patient care. Today, Dr. Rob will share expertise and latest findings with us, offering a deeper understanding of the importance of ethical considerations and the transformative potential of AI in our field. Please welcome Dr. Rob.
Right, thanks, Angie. That introduction puts a bit of pressure on me. Okay, yeah, so I have an hour or 50 minutes to talk about ethics. So I thought I'm not going to spend one whole hour on one topic. So I broke it up into two. But recently I saw a bit more information coming out about the use of artificial intelligence and how we can actually use it. But there's a large component of ethics that goes along with this. So I'll quickly also touch on that. How did we go? Okay, we have to use the mouse. All right. So my agenda, looking at ethics in AI in healthcare, in dietetics. Then I want to just quickly talk about ChatGPT. I don't know if I maybe can ask, who of you have tried ChatGPT before? It's quite nice, right? So all of you, have you tried it for your work stuff or your personal stuff? Both. Okay, so I'm going to show you a couple of examples of how you maybe can use it for your practice, for your dietetic practice. But obviously also then looking at the ethics and the risks associated. Okay, so the basics of AI is that it comes down to the machine learning part of it, these algorithms that are created. And it's in the simplest sense, AI is when computers mimic human cognition. And the types of AI in healthcare, so you'll see I'm going to speak a bit about what is AI, because I thought it's not very ethical to talk about the ethics of AI without Thank you. So I can't talk about the ethics of AI if you don't know what AI is about or how we are going to use it. So first of all, we have machine learning. So this, we can predict what treatment protocol will succeed or will be best. This is quite nice on the natural language processing. So yeah, AI can help us with speech recognition, text analysis, translations. What's also quite nice is I thought you can transcribe your whole conversation with the patient. So while you are having your consultation, AI will be typing it out. And I don't know, maybe you can email it to your patient afterwards, save it. Then obviously the physical robots, I'm sure you've seen this for the surgeons, but ultimately the human surgeon still is in control, luckily. And then also robotic process automation. This is more like computer processes with admin, like billing and stuff like that, that like very repetitive, basic administrative processes. So just as an example, in the medical field or in the medical specialities, it's been used quite a lot. I wasn't really aware of it, but in radiology, cardiology, etc., it's used especially for interpretations and diagnosis. So it's coming to dietetics. I'm sure it will come to us within the near future. Dietetics, we are implored to embrace these types of technologies. We can't fight it. It will come and we must see the advantages thereof. And that's also what the WHO says. But always acknowledge the possible risks or ethical challenges or the taking away of that human contact part might be challenging as well. So if you read about AI in dietetics or in healthcare, every single article will end off or will have a focus of the ethics thereof and the challenges. Okay, but in dietetics, there are a couple of examples of how it is being used for screening. This can be done for like public health, screening for labor laws, if you're transgressing that or not, but obviously in the clinical setting as well. So here, for example, it was used to detect malnutrition in quite a large sample of patients with cancer, and that model was very accurate in being able to predict nutritional status, etc., of that sample. Then disease and clinical risk prediction. AI models can help to predict a patient's risk of developing certain conditions and also provide recommendations for treatment. These researchers, Choi et al., used their algorithm to predict refeeding hypophosphatemia in patients. And the AI model was more effective than just your normal statistical analyses. Also, in the placement of NGTs, AI assisted these researchers in being able to place the NGTs better and not in an incorrect way. In dietetics assessment, especially for dietary assessment, there are also a couple of applications for that. And this was quite a nice one, I thought, doing a dietary assessment where you can just take a photo of your plate of food, and the AI system program will be able to analyze the macronutrient content, energy, etc. of that plate of food. And yeah, in this study, they tested out this AI algorithm against 2 experienced dietitians, and who scored the best with the macronutrient composition? The robot won. So the so the robot, the algorithm was more accurate than the 2 dietitians with just taking a photo. I think that's quite interesting. Also, we can use AI in prescribing, for example, parenteral enteral nutrition. I'm sure you are very well aware it's quite an intricate process, multidisciplinary process, getting the best prescription for your patient. A lot of assessment going on and monitoring, but the AI can rapidly, instantly almost, identify the best treatment protocol and to help you with this process. Virtual coaching, this also can tie in with that speech recognition, where I don't know if you've seen these chat bots where you can chat and they chat back and you can make jokes with them. And so it can be like a virtual coaching assistant, like encouraging you to go to the gym, encouraging you to eat better, things like that. Exciting. Also, autonomous meal planning. I'll show you an example later on. So these AI algorithms like ChatGPT can be used to generate personalized meal plans. And you can type in anything and it will try and give you the best answer. So I'll show it to you just now, and you can judge whether you like it or not. Okay. This was one of the blogs I found online. It's a dietitian, I think Mircea Zida, and she wrote this blog about dietetics and AI. And I like the quote at the bottom. It says, "It's like having a quick brainstorming buddy. For those moments you need a nudge in the right direction. It can be a starting point when you don't know how or where to begin." So if you play around with ChatGPT, you'll see it's very nice to bounce ideas off of it. Okay, but I think you can, after today, go and try it out again. And she uses ChatGPT, I'm sure it's ChatGPT, for the following. Recipe creation. So you can also say, I only have up and this and that in the house. Please generate the recipe ideas for me. And it's like instantly a lot of recipe ideas. Brainstorming, content production, meal planning, translation. It's excellent in translating. I think much better than Google Translate. Editing, etc. So you can also find out what works for you. So you must use it as a tool for you. Don't feel intimidated by it. I think you sort of like, it's going to take over my job, or that's not what it's about. You can use it to your own advantage. Okay, so I'm talking about ChatGPT. It's the original. It was released November 2022, and I think it took the world by storm, good or bad. But just as a background, interestingly, for the medical exam in the USA, so without any help or training or whatever, ChatGPT sort of passed the exams, the medical exams, so almost passed all of them, without any, use this textbook, use this PDF or whatever. Just in general, using the algorithm, it passed. So you'll see a lot of writing, dietitians writing about it. So I just screen grabbed a couple of the blogs. So ChatGPT surpasses dietitians in frequently asked questions. ChatGPT gives better advice than dietitians. The last one, please don't ask ChatGPT for diet advice. I like that dietitian. She's protecting her job there. But when you do want to use ChatGPT as a tool, just make sure there are a couple of issues just to consider. Remember, if you want to make any nutrient-based assessments or recommendations, you need a credible nutrient database. So for South Africa, we have the African food composition database for our foods, for example, that we use for research. So it's very credible. But if ChatGPT, if you ask it a question, it might just get the information from anywhere on the internet. We don't know where it's from. We don't know if it's accurate. So just keep that in mind. You can use it as a personalized meal planner. So I think you must try this after the session. Just go into ChatGPT and type it in, just for interest's sake. So this is an example from this article where they use this sample prompt for ChatGPT. I am looking for a personalized meal plan that can help me manage my weight on a vegetarian diet. I need 2,500 calories. I eat 3 times a day. I prefer Filipino cuisine. I have a peanut allergy. So it's very personalized. So I just took some screenshots of the one day, breakfast, lunch, and dinner. So instantly it gives these recipes. It even gives a recipe how to do it, what to eat, how much of it, additional notes. So you can, and they give a 3-day meal plan. If you don't like it, you can say, listen, ChatGPT is like a little slave almost, and it never gets mean, or it doesn't get annoyed. So then I can say, listen, I don't like tofu. Redo it without tofu, or rather add an afternoon snack, or I like some fruit in the morning, and it will just do it without complaining. So it is interesting. Okay, I'll show you a South African example just now. Also, dietary advice and guidance, you can ask it any question. So I've asked it, just an example, I've also asked it, explain to me what hypertension is, and it gave a very brief, easy to understand summary, like short. And then I asked, okay, now I want detailed pathophysiology. And then, then it brought its A game. It was like, then I asked, I want references in text, please. And they added good references. So it can really help. But you must be able to evaluate every single word and check it for accuracy. And does it make sense? And will it help or will it harm? So can you explain the difference between sat fats and unsaturated fats and provide recommendations, all of that? And sorry if it's a bit small, but now I just gave a nice, almost like a pamphlet information. And then I said, okay, please translate to Afrikaans. Instantly, beautifully translated. I'll give it 99% for translation. And then I said, okay, please translate to Sesotho, please. Okay, I always say please. You don't have to say please. I can't help myself. I always say please. But then immediately into Sesotho, which I'm also hopefully sure is quite accurately translated as well. So it can be a nice tool to have. It's much better than Google Translate, I feel, personally. Okay, so, but like I said, you must make sure that you check the accuracy of the information, because otherwise we'll just look like fools in any case. Okay, then assessment tools, now for also evaluating nutrient intake, etc. You can do that. Also calculating energy requirements, macronutrient requirements. So I have a hypothetical prompt here. I'm a female, 65 kg, 163 centimeters. I'm healthy, inactive. Calculate energy and macronutrients. Calculate a 3-day meal plan for a white South African woman. 3 main meals, an afternoon snack. Okay, so quite a common request. And instantly it's doing this. Like in front of your eyes. So it used Harris Benedict with an activity level of 1.2, activity factor, which is fine. It also, when I copied that same prompt in a week ago, it used the Mifflin and Jua. I don't know why. So it's jumping around, but they are both accurate to use. So 7,200 kilojoules looks fine. The macronutrient distribution here, it used the Institute of Medicine, the acceptable macronutrient distribution ranges, so it is correct. 50% carbs, 20 protein, 30 fat, and it's giving me a whole meal plan and macronutrient breakdown. So, I mean, I can now ask, listen, please explain or be more detailed with your portion sizes, and it will explain. And I've asked it, there was 150 grams of chicken, and I said, I don't have a scale. How can I estimate this chicken size? And it had a nice explanation there of, you know, the deck of cards or the palm of the hand, and a little bit bigger than that. And it was very nicely explained to do that as well. So, like I said, go and play with it. It's very interesting and fun, and see how you can use it. But here we are at the ethics part. There are some risks or challenges associated. So luckily, actually, the models can only deal with a small proportion. So you are still in control. You must still be there overseeing everything. Otherwise, it's going to be chaos. And also, what happens is if the data used to train this model or this algorithm is incomplete, or maybe only 99% of the recipes come from the USA or something like that, and only 1% from South Africa, it's going to be biased in its recommendations. So that can be a problem. The big thing that I was wondering about, if AI makes a mistake, who's going to be responsible? What's going to happen with that? So this is something that must be considered. And the ethics thereof. So WHO does recognize the promise of the use of AI, but there are ethical concerns. So in 2021, the WHO released Ethics and Governance of AI for Health. So a long document, if you are interested to go and read up. But I literally just highlighted the 6 or 5 key ethical principles because it's such a long thing to go through. I won't bore you with that. But the key ethical principles for when you want to use AI in health is that protecting human autonomy. So humans must still be in control. I think this is like that sci-fi scary when the robots take over. That's not what we want to go to. Humans must still be in control and monitor this process and be able to make the decisions. AI must promote well-being, so it must not harm people physically or mentally. And the designers must also satisfy the regulatory requirements in a country. It must be regulated. Everybody can't just do what they want. Ensuring transparency, so AI technology should be understandable to everyone. I think so everybody needs some training, just the background, how does it actually work? I think we can't be experts in this, the data analytics and all of that, but at least have an idea of what's going on in the background when we do use this AI algorithm or ChatGPT, what is going on? And also there must be meaningful public consultation and discussion before we do use one of these AI applications or algorithms. Then very important, somebody must be accountable. And I don't think a machine can be accountable or a robot can be accountable. It must be a human being. So maybe the creators or developers, or we must go and read up who will be ultimately accountable if something does go wrong, if recommendations made are not correct and implemented. But that's why you must still be there and overseeing this process. And ensuring inclusiveness, so it should encourage the widest possible appropriate, equitable use and access irrespective of age and race, etc. And lastly, it must be responsive and sustainable. So the designers must continuously check the application and what is this AI application doing in the world? Is it good? Is it bad? Is it working? Is it not? How can we change it? and it must still be sustainable. It must work with the sustainability of health system and environments. Okay, the big concern is, or was, that it might cause partial displacement of dietitians because, like I said, you can just say, I weigh this, I want to weigh that, this is what I usually eat, make a meal plan. But I'm sure you know as well, the counseling relationship that you have with your patient, that's different. It's difficult to replace that whole interaction. It's impossible, actually. So don't feel like, oh, this is going to take over my job. But the second bullet there was important for me. AI will actually change the way in which you interact with your patient or how you do the NCP. It's not going to substitute you. It might actually help you and assist you and help the patient as well. And that's what we want at the end of the day. Okay, also very important to minimize any risk. Clear statements about what the AI product can do is recommended and for who this is recommended. So lastly, also connecting with the previous slide, there should be a special note. I'm sure I've seen this as well while I was playing with ChatGPT. It will usually say, if I ask it, I want to lose weight, it will usually say, okay, these are some general guidelines, but go see your dietitian. It was so nice to see. It always referred, with a hypertension question as well, referred to, these are general guidelines, but please go and see your dietitian. So you have to nudge people into the direction of still seeing a healthcare professional and not just relying on the AI, especially where there are high vulnerability or possible mental disease or, like I said, vulnerability. For example, you can imagine there's a teenager without any supervision at the risk of developing an eating disorder interacting with this very powerful AI algorithm and virtual coaching and things going on that might be a bit vulnerable or might be a bit difficult or ethically challenging if there isn't the oversight of a professional, experienced person. Just giving perspective again in this process. Okay, so that's my AI talk. Angie, can you come share the other one, please? Angie knows sharing. I don't know if we have time for questions now or afterwards. If there is a question, like I'm not the expert in AI, but I don't know if somebody has a comment or maybe how you've used it. Oh, Prof. Louise, I'm sure she likes ChatGPT as well.
Yes, no, I just wanted to make a comment, and one has to remember it's just a machine, and you can actually go play around. It's all in the prompt, in how you ask the question, and that is where the person on the street, that's where the danger is for them, using ChatGPT instead of asking the dietitian or the healthcare professional, is because how you actually word the question, the amount of information you give, all of those things impacts on what answer you're going to get. And I think it is in that interpretation where the clinical discretion still lies. And I think that is also the way that we need to, advocate for use, that people know this, because otherwise there is this danger that a teenager will go and say, I want to lose weight. I want to do it in 10 days, It will tell you there's a danger, but still going to tell you how to do it, that type of thing. So I think there we've got a big role in advocating for ourselves and for that danger, not because we're scared to lose our jobs, but because, of the ethical of it.
Thanks, Prof. Okay, so go and play with ChatGPT. It's really fun. Okay, but the second half of my talk is maybe a bit more, I wouldn't say boring, but it's still important. It's just a couple of ethics aspects for us in South Africa. So I want to look at the dietitian scope of practice quickly, professional conduct, POPIA, which I think everybody is sick and tired of POPIA, but it's so important. And then also some social media ethics. Okay, so we know dietitians, we practice in 4 main areas, and in all of these areas, there will be a possibility of ethical dilemmas or problems or things arising that we are not sure of. So we know that the scope of practice of our dietitians and the ethics and professional conduct, we are regulated by the Professional Board for Dietetics and Nutrition under the HPCSA. And we have these regulatory guidelines for all healthcare practitioners, patients' right charter, all of this, withholding, withdrawing treatment. These are those booklets. I'm sure you know about those HPCSA booklets that you must download and just keep handy because it's like our law that we must follow as a healthcare professional. And I can never remember where to get it, so I took a screenshot. It's at the public HPCSA website, and then you go under core operations and then professional practice. So it doesn't jump out ethics, but there you will find those booklets, those PDF ones that you must please go and download and just have on hand and check now and then. Okay, there's a direct link as well if you want. So on that page, we have those booklets, all of them. And at the bottom, it also says the following includes unprofessional conduct against which the HPCSA may take steps. So maybe these are the ones that they see more often in their cases. So things like advertising in that unprofessional way, criminal convictions, improper relationships with patients, excessive fees, incompetence when you treat a patient, even just rude behavior. I think that's not for us. The dietitians aren't rude. I think that's other professionals, not us. But look at these and make sure that we are not getting into trouble. Okay. So looking at the professional conduct. So what is professional conduct in our practice? You must be compassionate, you must act with discernment, you must be trustworthy, have integrity, be conscientious, and have honesty and be fair. So it's a big ask to do it all at once, but it is at the core of our profession, very important. Also, the nitty-gritty stuff, like how do you advertise, how do you name your practice, if you share a room, all of that is also in the booklets. So I think especially before you start your private practice, students, if you want to, go and read all of those very important booklets and ethics. Even when you start to name your practice, you must first go and check the ethics of it. Okay, so what is ethical misconduct? Unprofessional, it is improper, disgraceful, dishonorable, unworthy conduct. And we should obviously avoid that. So it is mentioned, what should we do? We shall confine him or herself to the performance of professional acts in the field of dietetics in which he or she was educated, trained, and has experience. So you must have experience before you can actually treat this patient and be competent in treating this patient, that condition. And we shall not fail to communicate and cooperate with other registered practitioners in the treatment of a patient. So HPCSA actually forces us to work in a team and talk, and because that is ultimately best for the patient. So this is a bit of an older study. I couldn't find a newer one, but there were 7 guilty cases of misconduct in that 7-year period. It's a while ago. But so it's only, in that 7-year time, we only had 7 guilty cases of dietitians. So 1 a year, it's not bad, I think, but you do not want to be that one in that year, right? So negligence or incompetence in treating patients, etc. So let's not become a statistic, I think, in the newest article, updated article that is published. Okay, POPIA, protection of personal information. For healthcare workers, so it's more applied to healthcare workers. So there's a whole law, a massive amount of literature regarding POPIA, but I only extracted small amounts of it. So looking at what is lawful information processing, there are a couple of principles. that you can lawfully process personal information. So the first one is the principle of minimality. So whenever you obtain information from a patient or client, you should obtain as little as what is needed, not more, because why would you want more than what you need? So information should only be processed to an extent that is adequate for the purpose, the relevant purpose. So for example, photographing only the section of the body that is being treated, if you need it for follow-up or future education or whatever, and not the whole patient or the entire body of the patient. For example, it makes sense, right? Why would you want all of the other information? Then informed consent. So you must get informed consent from your patient. So this includes the principles of being competent, doing it voluntarily, and you must disclose any pertinent information before that patient can give consent for you to use their personal information. It can be written or verbal. I think written is stronger, but if it is verbal, you must just note it in your clinical files. This patient consented for me to obtain this personal information. If you are going to talk to another healthcare professional about it, you can also write there, this person has given verbal consent for me to talk to another healthcare provider about this person, the condition. The third principle is you must collect data from the data subject themselves. So this is trying to get information from the patient, him or herself, because in theory, it will ensure better accuracy of the information. Then collection of data must be related to a specific function or requirement. So almost like I said previously, collect personal information that is needed for billing only. This is why you are collecting it, not for anything else that is irrelevant. Okay, you never want to obtain irrelevant information. Or if you are going to take a photo of the wound, but it must have a specific purpose. You can't just take it for fun. There must be a purpose related to it. Either for follow-up, if you want to publish it, but that's a whole other area of ethics, consent, but there must be a reason for it, not just for interest's sake. Okay, and then reasonable security regarding the safeguarding. So processing and access of personal information must be restricted. So if you have hard copies of documents, or whether it's on your phone or on your PC or on your laptop, there must be passwords and locked away and stuff like that. You can't just let it lie around and people can read other patients' personal information, obviously, and diagnoses. So these are examples provided by this author regarding illegal information processing. So maybe let's look at it to see if we do it or not. Because so taking a photograph with your phone of a patient's wound or any part of the body without consent. So just make sure you have consent before you take photos. Taking a photo of a hospital label and not securing it. So anybody can find it on your phone or on your laptop, it's open. That's a problem. Linking to that, storing any patient information on a cloud or data bank where it's sort of not really protected with passwords or heavily protected or anything like that. Accessing patient information like blood results, etc., on a public computer and just leaving it open, obviously. But you can also go and sit in a coffee shop with your laptop and all the patient bloods and biochemistry is open and the name is there. Just be mindful about this, that we don't put our patients at risk. And the last one is sometimes a bit difficult for me. It's also in the research arena the same. So storing patient information without legal research or admin value for longer than 5 years. So actually after 5 years, you should be destroying these documents unless there is anticipated legal research or admin value for you to keep that information. So just go and think about this. If you have patient information, documents and things on your PC in a cupboard somewhere older than 5 years, just make sure, why am I keeping this? Is there possible legal research or admin value to this? But before you go and destroy anything, I think maybe just look at your hospital, your clinic's policy for copia and destruction of any documents. I think that's also important to look at your local policy as well. Okay, then a couple of recommendations. So always inform the patient if acquiring their personal information, notarizing the type of consent. Was it just verbal or did they sign for it? Remember, written consent is necessary when any information will be disclosed or published. So if you want to use this patient as a case study or publish it somewhere, put it on your social media for whatever reason, send that information around, that patient must give written consent. And that patient must not be identifiable at all. So that's very important. I always think about, sometimes you think, okay, I told this case study on my Facebook about this nurse and the diagnosis that she had and what I did, but I didn't give the name of the nurse, so it was now anonymous, right? But just keep in mind, sometimes you can still identify somebody by the background information. So if you maybe say, okay, I'm at Pelonomia, I'm a dietitian working there, I have this nurse, she consulted with me and she lost so much weight. This nurse is the oldest nurse, she's 95 years old. I mean, there's only one 95-year-old nurse at Pelonomia, right? Or whatever, this is now a silly example, but sometimes you can, without giving a name or anything, quite easily figure out who this person is talking about. So guard against that, because you are then basically giving away who this person is and what's it about. Okay. The recording of personal information should be done accurately. Like I said, get the information from the data subject as far as possible, obviously. Ensure full de-identification or anonymization of any information that you want to disseminate, publish, send around with written consent of that patient. Those are the two things that you must be in place: written consent and de-identification. Okay, and then you must also retain your records as per your policy, let's say. POPIA recommends 5 years, but I will also ask you to just make sure with your hospital or clinic or wherever you are working, what is in the policy? How do you handle, the destruction or retention of documents? So here it is again. Deletion of records after 5 years, retention is necessary except for historic, academic, or legislation or administrative value. Okay, and yeah, I've mentioned also the POPIA policy that must be in place. So if you are in your own private practice, I'm sure you must also have your own little POPIA policy in place. So keep that in mind. Okay, briefly, lastly, looking at social media, it does tie in with POPIA because social media is sometimes used to share information from patients as well. So for the DTs in South Africa, it is a nice platform, these professional networks and for education as well. So yeah, according to HPCSA in 2019, this is what they classified as social media. So Facebook, Twitter, WhatsApp, Instagram, YouTube, etc., blogs. But I think it should be updated. Twitter, X now, and TikTok is bigger than all of these. So keep in mind, social media is developing rapidly. So what are some of the pitfalls? But when you do use social media, what can go wrong or what you shouldn't do? Tying in with the POPIA, publishing patient information without consent, written consent, breaches of patient privacy and confidentiality. This is when you do not anonymize the information for which you have written informed consent to publish. Also just plain old since that you are publishing, so poor quality of information that you are publishing. So always get your references in your little social media post that you want to give. Give your references, give good quality of information on social media. There's also the possibility of a violation of the patient healthcare provider relationship. So if healthcare providers interact with patients on social media, there might be a violation of this relationship going on. And I'll explain a bit later as well. So I'm sure, yeah, it's not difficult. Bloemfontein is so small as well to interact with either patients, or you see your doctor somewhere and you are interacting outside of the medical setting or healthcare setting. So we will look at that just now. Because I mentioned in 2019, the HPCSA did release another booklet for social media. And I think ATSA also has recommendations for social media use. There are a couple. Definitely go and read it up together with all the other booklets, just to protect yourself and your patients. So regarding confidentiality, healthcare practitioners can share confidential information with other members of the team involved in that patient care, but the patient must give consent for the personal information to be shared with other people. Like I've said previously again, you must have written consent, informed consent, and de-identification before you publish according to PAPIA, and just good general social media guidelines. Also, if the patient is under the age of 12, you must get consent from the parent, written consent with a sign, and the child can give assent to say, okay, you may use my information, or no, I don't want you to use my information. And we obviously respect that. And also healthcare practitioners must ensure that the recipient of information via social media understands the information given to them is in confidence. So I mean, if you are WhatsApping about a patient or something like that, or on a group WhatsApp, for example, a work WhatsApp, you're discussing patients maybe, that must be done with caution as well, I think. And also, just make sure that some of that information doesn't sort of leak out of the group. And who has access to your phone, who has your phone password to be able to look on these groups and see patient information? It should actually be restricted to only you, I would say. Okay, the practitioner-patient relationship. So this is interesting. Also, the guideline advised that we should not interact with patients via social media, as failing to maintain a strictly professional relationship may result in ethical dilemmas. So I think this is like on WhatsApp, in comment sections of TikTok videos, stuff like that. Chatting back and forth can be problematic. And this is very interesting as well. It says, the guideline, when you refer to PAPIA, state that the Act outlaws the acquisition of data pertaining to a patient's health or sex life outside of the healthcare or clinic setting. So I don't know, I interpret this as like you are like at a braai and you're talking to your doctor, you're sort of friends and chatting about it. I don't know. You should not be discussing your health with your healthcare provider outside of the healthcare or clinic setting, outside of an appointment to discuss your health and the reason why you are discussing or you have an appointment with this person. Okay. So, and then furthermore, by having access to patients' social media profiles, we may find ourselves privy to personal patient information that has not been shared in the healthcare setting. So now you are seeing on Facebook, oh, my patient, uncontrolled diabetic, but eating 2 liters of ice cream on Sunday evening and doing this. And they say they are exercising, but no exercise is going on. So this is information that you are not getting in the healthcare environment, in like an appointment counseling session, which is discouraged by these regulations. Okay. Also, a difficult example, if you get a friend request from a patient that you know in a non-professional setting, like you're friends, but you're also this person's dietitian or doctor. So here the guidelines state that in such instances, you should apply yourself and weigh the positive and negatives of accepting such requests. So think it through. I know sometimes with the students, when they used Facebook more in the past, you get a lot of requests while they are students, and I never accepted it while they are students. I waited until graduation. Then I would accept their request because I just felt it's a bit of it's just too close for me to protect them as well and to protect me as well. Okay. Yeah, very important as well. The guidelines state that you should ask the patient to set up an in-person appointment if they are seeking health care advice. So if you maybe have a Facebook page as a dietitian and somebody comments, I have a food allergy, what must I do? Rather just refer to a dietitian, refer to make an appointment, please, and we can discuss this either with me as your dietitian or any other registered dietitian. Yeah, and the guidelines also discourage providing health or medical advice via social media to patients with whom the healthcare provider has not had a relationship with. This was that whole Prof. Noakes situation. You cannot give advice over social media in the first place, specific advice, because you've not done your first step of the NCP at all. You've not done any assessment of this patient. So how can you give advice or personalized individual advice? So don't do that. You can share information in general. So if you want to share information on your social media page, maybe you want to talk about vitamin A and how important it is, you give generic information regarding vitamin A or whatever, and evidence-based, obviously. And then you must also say, please visit your dietitian or make an appointment for more personalized discussion and treatment options for whatever. Also important, rather have two social media profiles, separate them, your personal one and your work one. It shouldn't be sort of mixed together, you partying on the weekend and then you have your professional advice being given and it's just not going to gel. It's not professional. Have your professional page and your personal stuff separate. If they do say, and this obviously happened then, if patients persist in communicating with you, maybe direct messaging you, sort of they don't get the message that you must make an appointment or whatever, then you can actually ask HPCSA for advice as to how to handle this situation. And that also protects you now going further because you have reached out to the professional people to help you with the situation and to guide you. Also, a healthcare provider who uses social media in their personal capacity should remember that their personal activities can also bring the whole profession into disrepute. And I'm sure all of us have looked like this guy when I say, what is this person posting on Facebook? What are you doing? Why would you publish this for everybody to see? It's not appropriate. And now you know this is a doctor or dietitian or whatever. You're sort of bringing the whole profession into disrepute. Just remember, I think in general for everybody, anything that you post online may be shared outside of your control, the entire world. It can be shared within minutes to the entire world. And unfortunately, it can be taken out of context, whether intentional or not. And my last slide, for those of you looking for a new job or new employment, just remember, it is well known that future employers do look through your social media profiles and see, okay, now this person, I don't think I align with the values of this person just by what they publish online. So rather play it safe than sorry, I would say. Thank you so much. I don't know if there's any comments or questions. Maybe somebody has an example of how you use social media ethically or not ethically. I don't want to hear about it now because then, yeah. Oh, is there somebody in the online? Where?
Thank you, Dr. Rob. She's just going to read the online chat for us.
Okay, from Mika, perhaps it is easier to have a personal social media profile and then a professional one as well. Okay, Mika, haha, never mind. All right, good. Yeah, because I said that. I think that's a good idea to separate it completely And I would also put my personal one very private. Only good friends can see my photos and things like that. Thank you.
Thank you very much, Dr. Rob. We can give her a round of applause. I think she did a good job. All right, ladies and gentlemen, it's my great honor to introduce our next distinguished speaker. We've all know her, we've all been taught by her. It's Dr. Etoy. She is renowned for her expertise in sports nutrition, bringing a wealth of knowledge and experience to our symposium. She has dedicated her career to advancing our understanding of sports nutrition, helping athletes optimize their performance and health through evidence-based dietary practices. Her research and practical insights have made significant contributions to the field, influencing both academic and applied aspects of sports nutrition. Today, she will be presenting on the latest advancements in sports nutrition, offering us a glimpse into cutting-edge research and innovative strategies that are shaping the future of athletic performance and wellness. Please welcome Dr. Etoy.
Okay, good morning. It's not a sports injury that I have this morning, but let's see what we can do. I'll try not to cut on my presentation time, but let's see if I can share the most important part with you. Okay, I'm not going to say what we are going to talk about, but basically it will be energy drinks, energy shots, caffeine, coffee, the female athletes, and sodium bicarbonate. As you heard this morning, there's always development taking place, and sports nutrition is no exception. So, but we need as professionals to keep up with these developments. I mainly based today's presentation on the position statements of the International Society of Sports Nutrition, the ones published in the last 3 years. And then I also want to share with you a book. The students know it very well. It's a book by Bean. She does a lot of research. She's an eminent sports nutritionist in the UK. And this book is very well written if you want to make recommendations for your patients. So the first position statement is on energy drinks and energy shots. So we all know those are pre-packed functional beverages, and the difference between sports drinks and energy drinks is the caffeine content. It contains various ingredients, and these ingredients may differ from being present in a small percentage to up to 100%. They are mainly marketed towards the active younger adults and adolescents market population, and they also represent the majority of the consumer base. There was a study done, it's an older study, but this was done in 2013, and they say their users, it was different European countries, 68% were teenagers and 30% were young adults. But in a sub-analysis, they said that 12% of these participants were high chronic users with an average intake of 7 liters per month. To me, that was quite shocking. So after that, about 3 years later, there was a study done in Canada and Germany, and then the adolescent market was 62 and the comparable younger adult percentage of 61%. So they made the conclusion that young people already find this drink very popular and they use it to a large extent. Just to explain what energy shots are, It's similar to energy drinks, but it's more concentrated, and they are sold in volumes of between 60 and 150 mils. So they both contain nutrients that may affect to improve mental or physical performance. But most of the evidence that we do have, it is on the caffeine and or carbohydrate content. There's some available in South Africa, but I found it difficult to find some because I wanted to see for myself what's available in the shops. So maybe I don't look at the right places. I'm not sure. Okay, let's move back to energy drinks. It can improve acute aerobic exercise performance if you consume it in dosages of more than 200 milligrams. Some of you may remember that a strong cup of coffee might give you 100 milligrams, or if you consume it, if there's more than 3 milligrams per kilogram in the beverage. Once again, it comes back to the same things. It was two different sections in the article, but it's based on the evidence we have on caffeine and carbohydrates. So the ergogenic value is that caffeine will improve mental and physical performance, but the potential additive benefit of other nutrients need to be determined. So it is recommended that if you take one of these drinks, is to take it 10 to 60 minutes before exercise. I'm not going to include all the benefits, but it's mainly on anaerobic performance and endurance performance if you take 3 milligrams per kg body weight. And they say that the maximal lower body power production will be obtained with this dosage. I don't know how do you distinguish between the upper body power production and the lower body power production. Also of benefit in endurance exercise, repeat sprint performances, team sports, but there are numerous other ingredients, as I said, that are not studied or have not been studied, and we need information to say if it's efficient or safe to use. Then my other interest is this low energy energy drinks or energy shots for training and or weight loss, because I've seen in the gym that the ladies that need to lose some weight has got their sports drinks and some have their energy drinks with them. I don't know. Why do you exercise? Okay, it's for other reasons as well. But if you want to help with weight loss, don't use these drinks, because if you go and look at the energy content, the carbohydrate content, it is pretty high. But they say it may help with weight control because you will be able to train better. But if you go and use the higher energy drinks, it even can contribute to weight gain, because unless you calculate it in your total daily energy intake. And for those who have metabolic health problems or blood glucose problems and insulin levels, we also need to consider the high GI of these products. If we look at the teenagers, they say they should use it with caution, especially if they use a high caffeine content drink of more than 400 milligrams, because we do not know if it's safe. There's limited evidence. So it's not recommended for children between the ages of 2 to 12 years during pregnancy, if you try to before pregnant, during breastfeeding, and if you are sensitive to caffeine. If there's other chronic diseases present, we need to look at, and they take medications for that, and those medications may be affected by the high glycemic load foods and caffeine or other stimulants. You should take caution, and it's better to consult with your physician beforehand. Once again, we do not know all the answers. A lot of research is still needed because we don't know what is happening with the other nutrients and the possible side effects. And they say the indiscriminate use of multiple servings per day, and I do know from our past students that some of them are totally addicted and they still want me to try one of these energy drinks, but luckily up to now they haven't done that because it may have adverse effects. The next one is coffee per se and sports performance. Remember that coffee consists of other components as well, and we do get a wide range of consequences and things that may help, but it was found in most but not in all studies. So for some coffee intake will be beneficial, but for others it won't be. And it's mostly demonstrated in men once again and not in females, but the effects could be also to the caffeine per se. More research is needed. The recommended dose is 2 to 4 cups of coffee, hot coffee, depending on body size, to get to 3 to 6 milligrams of the chlorogenic acids. That will be approximately 100 to 400 milligrams an hour before exercise. There is a history of controversy. There are side effects, but mostly coffee will be safe and beneficial for healthy exercising individuals. It could also be a vehicle for the other dietary supplements, but we need to remember it can interact with other nutrients as well. There's shortages, not enough literature we don't have all the answers. That is the bottom line. And we need to look at coffee on the one hand, but we also remember that we can get caffeine from capsules and energy drinks and pre-workout drinks. So we can't compare the two with each other. Then caffeine and exercise performance. There will be a slight duplication, but I'll try to skip that. Once again, it may improve performance. The effects are small to moderate for different activities. We see the larger benefit, the moderate to large benefits in aerobic endurance. But we need to remember that there's a difference between individuals. And the dose is for caffeine specifically 3 milligram per kg. The minimal dose is estimated at 2 milligrams per kg, and then the very high dosages have more side effects, and it will not necessarily have an impact on performance. Okay, we all know that we feel better after a cup of coffee. If I had a bad night, it does help me, but I am a tea drinker for those who know me. It will improve and may improve cognitive and physical performance under conditions of sleep deprivation. And you can combine the caffeine and endurance exercise in the heat and at altitude, and there's a small difference in the recommended dosages. As I mentioned before, we also find caffeine in mouth rinses and energy gels and things like that. And the energy drinks and the pre-workout drinks can improve aerobic and anaerobic performance. Then the female athlete, this was a very interesting position statement for me as well. The males will say we have a unique hormone profile. I'm sure we will agree, but not all our sites are due to our hormones. But they say during the reproductive age, we should track the hormonal status against training and recovery to determine individual patterns and needs. Peri and postmenopausal women, once again for that, is also important to track how they react to exercise per se. And very important, I know it is a challenge, especially during the teenage years for specific females, They don't want to gain weight, but we need to make sure that they have an adequate energy intake to make provision to meet the energy requirements and also for optimal energy availability. So they should focus on the timing of meals to see how they will react and how will they perform, and they must in the end still be healthy. The significant sex differences in sex hormones influence carbohydrate and lipid metabolism. So we need to ensure that they get in enough carbohydrates across all phases of the menstrual cycle. And the carbohydrate intake should be tailored to the hormonal status. And it's the greatest during the active pill weeks if they use oral contraceptives, or during the luteal phase of the menstrual cycle. That's the second part of the cycle, because there's a greater effect of the sex hormones on the suppression of gluconeogenesis. Once again, if we look at the protein quality, very important. I find it's one of the most important things for athletes to use just before and or on completion of their exercise, to make sure that they have enough proteins. But the recommended dose here for females is 0.32 to 0.38 kilograms per kg. And during the luteal phase, it is very important, that second part, that the upper end of the range is met. We've talked about the protein intake, but we need a high essential amino acid intake at the beginning and at the end of exercise, and that is about 10 grams of intact protein sources or supplements to overcome anabolic resistance. So the daily recommendation regarding proteins is between 1.4 to 2.2 grams per kg per day, but important to spread it out throughout the day. I've seen many athletes that like to eat one big piece of protein at the end of the day, but we also know that if you spread your protein throughout the day, that it will also help with muscle protein synthesis. And once again, during the luteal phase and peri and postmenopausal women should aim for the upper end of the range. The hormones also play a role in fluid dynamics and electrolyte handling. Females have a higher predisposition to hyponatremia in times of the higher progesterone levels, and also in menopausal women, because they are slower to excrete water. Females have less absolute and relative fluid available to lose via sweating if we compare it to males. And once again, the luteal phase is important here. And then there is still lack for sex-specific supplementation. So we need more research. Then also, if we look at the research done on females, caffeine, iron, and creatine has been mostly studied. Iron and creatine are very effective. If creatine in a dose of 3 to 5 grams per day is used, it can have a lot of beneficial benefits. You can have a look there. And then once again, the postmenopausal woman must have an intake of higher dosages, and it is for the caffeine 0.3 per kg per day. It is important that we need more high quality research. So they advocate that females should be included in the research unless the primary endpoints are directly influenced by the sex-specific mechanisms. It is very important, and it's a new role for us as well, to look at the hormonal status, including the menstrual status, the days of menses, the duration of the cycle, and if they use contraceptive hormones, or if they are menopausal. That should be studied because it will have an impact on their performance. Then the last one is sodium bicarbonate. A smaller dosage of between 0.2 to 0.5 grams per kilograms can also help with certain endurance activities. It can be used in combat sports and high intensity cycling exercises, but doesn't make sense that it is used for endurance, but mostly it is for high intensity exercise between 30 seconds and 12 minutes. The research we have has shown that we can use single or multiple bout exercise, and the sodium bicarbonate is beneficial or can be beneficial in males and females. If they talk about the single dose supplementation protocols, it's a lower one of 0.2 gram to increase exercise performance. They say the optimal dose is 0.3 grams. The higher dosages of 0.4 or 0.5 may be required in the single dose protocols, but it will not provide additional benefits, and there's more side effects. So for single dose supplementation protocols, you should take it an hour to 3 hours before exercise or competition. The long-term use, they say, on a daily basis may enhance training adaptations, such as increased time to fatigue and power output. The most common side effects are bloating, nausea, vomiting, and abdominal pains. The incidence and severity of the side effects vary, and it could be very low, but it can have a negative impact on performance. So if you are prone to side effects, stick to the lower dose. Take the sodium bicarbonate 3 hours before exercise, or adjust it according to your side effects, but very important to combine this with a high carbohydrate meal. And they say entry-coated capsules may also minimize the likelihood and severity of side effects. I think this is about the last slide. They is combined with creatine and beta-alanine, and it may have additive effects on exercise performance, but it's still unclear if we combine it with caffeine and nitrates, if it will have an added benefit. But another important thing and interesting for me was that this improvement in performance could be placebo-driven as well, or seems to placebo-driven. So mostly the protocols, it's for 3 to 7 days. There are the dosages. So rather give smaller dosages like 0.1 to 0.2 grams per kg during each meal, and then they will experience less side effects. So in conclusion, we can say energy drinks and energy shots can improve performance, but we need to look at the total daily intake. Coffee has been shown to be of benefit, but it was not found in all studies. Caffeine can improve aerobic and anaerobic performance. We need to start looking in more detail to females during all stages of life to help them perform optimally. And sodium bicarbonate can increase performance, but you need to stick to the dose. And I think very, very important to warn people not to take more than the recommended dose. We as healthcare professionals need to stay on the top of our game. I want to thank you for attending today. And these are the references. I just want to tell you about this very interesting article on the dark side of energy drinks. You can have a look at that. And then I want to thank you. Are there any questions?
Hello, doctor.
Hello.
I also wanted to mention on the caffeine that if someone really wants to further into for the competing aspect and everything, you can also check if you're fast or slow metabolizer of caffeine, which could maybe point you even further into the direction of whether caffeine would actually help your performance a lot or not. And then, I don't know if I missed it, maybe, on the creatinine, is there a recommendation as to from what age it is?
Creatine or creatinine?
Creatine, sorry.
Creatine. Yeah, the last is still that it is not before the age of 18 years, but I also know that at some schools, they really advocate the use of that, but we don't have evidence to show that it's better not to use it before the age of 18.
Thank you.
Thank you for sharing your information with us. There's another question.
Thank you. There's an online question from Tamarin. How does one ingest sodium bicarbonate?
Okay, they normally mix it with water and then they drink it. But as I said, it's also important to eat it with a high carbohydrate meal. I don't know if I will feel very well to go and exercise after I had this thing. And I was always worried about the side effects of too much sodium bicarbonate. Thank you. Does anyone else know if there's another way of getting this stuff into your body? Yeah, there's maybe over your porridge. I don't know if it's going to work, but it will taste different. If I can taste the probiotics on my porridge, I will taste this as well. Who's going to do that? Okay. Maybe there's an area for some new research, but I'm not going to do that research. Thank you very much. Yeah, and my water bottle.
Thank you very much, Dr. Du Toit. Even a moon boot can't keep her down. Ladies and gentlemen, we are going to break now for tea. Tea will be served in Metro 4 for our face-to-face delegates. There are also exhibitors in Metro 4, so please be sure to visit their stalls. For our online delegates, the exhibitors would like to share some information with you online during tea time, so please do not log off. And we will resume at 11:05. So we will all be back here at 11:05. Enjoy tea. Ja, maar dit kan ons dalk, want ek you ban as kies you pass.
Fitting in your vibe and you'll be styling out too quickly. Man, it's just the way you do it when you move swiftly. Vibing out to you, making me do you, man. Smoking out the way I feel motion. Motion, so good is so bad, it's so bad, it's so new. I'm wishing at the end of June. Clouds in my shroud, in my vision grow clearly. Can't see ahead if I'm fine when I read. What is the saying when you should let go? What is so I'm fine like that, fine. I'll never be losing. I want every time. Oh, you know, it's no better like a lie. Written in your style, not too quickly. And it's in the way you do when you move so swiftly. Vibing out, do you make me do your man? Smoking out the way I feel emotion. It's so good, it's so bad, it's so bad, it's so new. Wishing at the end. True. Clouds in my shroud and my vision clearly. Can't see ahead if I'm fine when I believe in me. What is it saying when you let go? What it's so impossible. So do me like that with smile, with lips red, with up your nose, you know better like that. When we be on the sea, when you come at me, wing at me with love. No rainy, no windy, no sun. Just music and just you one. I'm fine like that, fine like that, fine. I'll never be losing, I'm on every time.
Like the jam. Can't do it like that again though. I would have to listen to it a lot of times and then memorize it and then try to structure it and realize that I should have just done nothing.
Up from above it, don't leave me behind. It's round all the earth, it's divine. When I'm empty and all of my mind, I see.
Hard and do it good. Slow down. Slow down.
this ocean, traveling in slow motion, paddling with no question, early morning with the sun, not yet burning, innocent, but trying to be a good son, myself 100%. I feel it inside. I wanna reach that. It's somewhere inside. I wish I reached that. Skyline, skyline. I wanna reach that skyline. Skyline. I wish I reached that skyline. Skyline. I'm gonna reach that skyline. Skyline. Endless troubles to go through. They are strolling in the city. Daily struggle to be true. Betray authenticity. Poison all around, but still I will take another round or another route until we take off from the ground. I feel it inside. I wanna reach that. It's somewhere inside. I wish I reached that. Reach that skyline. Skyline. I wanna reach that skyline. Skyline. I wish I reached that skyline. Skyline. I wanna reach that skyline. Skyline. endless lies and learning. Who am I really? 26 and still searching. Oh, wait to know, wait to know. But this other me is again living. I'm blessed, but I'm not really aware of it. We're all blessed enough, but we don't really care about it. What's wrong, what's right? And which side is my body standing? Is your way mine? And is mine and yours fitting? Wanting more, but seeing myself disappearing. Playing those same two chords. What if that is what I would have done as a kid? I'm blessed. We are blessed. I'm blessed. We are blessed. I'm blessed, but I'm not really aware of it. We're all blessed enough, but we don't really care about it. I'm blessed, but I'm not really aware of it.
Ladies and gentlemen, welcome back from our tea break. We begin the next session with our distinguished guest and esteemed speaker, Professor Louise van der Berg from the Department of Nutrition and Dietetics. Affectionately known as our Minister of Sustainability, she is a leading authority on sustainable diets. She has dedicated her career to understanding and promoting sustainable dietary practices that not only support individual health, but also contribute to the well-being of our planet. Her pioneering work in this field has been instrumental in shaping policies and practices that encourage environmentally responsible and nutritionally sound food choices here at the University of the Free State. Today, she will be presenting on what a dietitian should know about sustainable diets, offering us invaluable insights into how we can integrate sustainability into our dietary recommendations and professional practices. Please welcome Prof. Louise.
Okay. Good morning, colleagues. Yeah, I don't know if I quite agree with that one. I can tell you that I'm going to share today with you things that I also thought, yo, I didn't know this, so maybe you know it or you don't know it. But I think I can safely say nobody in this room, probably nobody alive, is not aware that the planet is under threat. Sustainability has become the buzzword. We hear about global warming, biodiversity loss, etc., on the news media and social media every single day. But what we might be, and what I definitely was less attuned to, is what this means actually in the food system and how that might impact me and my profession. So in this presentation, I'm going to take just a quick flyby. So a bird's eye view of the history of our food system, the environmental impact and the health impact, and how we got to this point where we need to talk about sustainability within planetary boundaries and within health boundaries. What does that mean? I will be going to share with you two conceptual frameworks that has been developed that really, makes it easy to think about these things. of how the food supply system and diets talk to each other and how that influences health outcome, and try to elucidate, is there a role for us as dietitians? And of course, with dietitian, I include nutritionists in this system. Okay, so it was in 1948 that the United Nations actually enshrined the right to food. And it is actually the right to feed oneself in dignity. And the pillars of it is availability, accessibility, and adequacy. Of course, you'll recognize that this sounds a lot like food security. And of course, it actually means that the right to food is the right to have food security. This is enshrined in our constitution, in many constitutions in the world. How we get from the right to food security is through our food system, and the United Nations defines the food system as including the related resources, the inputs, production, transport, processing, manufacturing industries, as well as retailing and consumption of food, and the impacts that it has on environment, health, and society, and we'll unpack that a little bit. It all actually starts and ends with this slide. What you see here is the size of the world population from 10,000 years ago, that is just, after Paleolithical times, so this time trajectory is the modern man. And you see that we had this long lag phase, and then all of a sudden, with the onset of the previous century, we have this explosion in world population. If I fly in a little bit more, okay, I just want to say here, it was very interesting for me that global life expectancy before the 1800s, the median was 30 years. Now it's 73 years in 2023. So that played a role, but what probably played a bigger role is what you see on here. You all still remember microbiology? And we learned this bacterial growth curve. If you grow bacteria on a petri dish where you've given it its nutrients, it will have this long lag phase and then all of a sudden start growing exponentially. And as it excretes its byproducts and uses up the nutrients in the medium, it will eventually reach this flattened out phase. And if you don't intervene, then it can start dying off. And this is, of course, I think, important for us to realize, is what we don't want, is for the human species to go the same way. So if we look at this, flying in at a little bit greater resolution, we see that this exponential growth started around about the 1950s, and we are at this stage in 2024, sort of 2/3 up this growth curve. Then by all calculations, we will, by the end of the century, start flattening out at around 10.5 to 11 billion people, after which it might start declining, but we don't want it to be dying off, because we've used up everything, but rather as a consequence of our decrease in productivity. And you can see this has been actually going on for decades, where before you would think, in your mind, that the population growth is still very high in some countries. But even in India, for instance, that had a very high population growth around about the 1950s, it's only 2.4 children per couple now. So, and the same in South Africa. But anyway, this really hit hard in the 50s. And by 1966, there was actually a World Summit about the fear of global starvation. And there was extensive starvation in developing countries. And the singular focus in this space became to produce more food, to increase food security, to get to a point where we have global food security. And a great role was played by the Green Revolution. There's also an animal revolution. But the Green Revolution is a period that began already in the 40s, in which plant geneticists used traditional methods of crossbreeding, first of all, later on the GMOs, and that they looked for plants with desirable traits that had larger, more nutritious seeds and fruits and were more resistant to pests and disease. This all gave rise to an era of intensive monocropping, so clearing large pieces of land to plant one crop. If you do that, you take away the whole biodiversity of that area. Now you have to add the fertilizer, and you've also taken out all the natural enemies of the pests, so you have to add the pesticides. And they focus chiefly on wheat, corn, and rice. This was successful, and as a result of the Green Revolution, by the 1990s, we actually had food security on a global level, so per capita. What was really the consequence of this was the yield soaring in India, China, and Latin America, and the prices dropped globally. And in a sense, specifically in India and China, this turned over the GDP and the development, and we know, we see the results of that now. Okay, the Green Revolution, however, only targeted certain crops that grow in rich soils with ample access to water. So our unintended consequence was that Africa didn't really benefit from it because of our harsh conditions for agriculture. So there's a big space there for food scientists to develop the type of crops that will grow in our situation, but also political instability and lack of infrastructure all added to it. So we really start inequitably with this whole race going forward. However, our food system that achieved by the 90s food security on a global level per capita, enough food to feed everybody in the world, theoretically, also had a huge environmental impact. And I think this study by Poor and Nemec in 2018, they put this picture together that really summarizes it. If we look at just the food system, producing food for humans to eat, that produces 26% of our greenhouse gas emissions. If we look at land use, that uses 50% of the world's inhabitable land. It draws 70% of our global fresh water. And then if we look at pollution, it adds alone almost 80% of the global ocean and freshwater pollution. What to me, I suppose, as a biologist in a sense, is, was most shocking was that if you look at mammal biodiversity, 94% of global mammal biomass, excluding humans, is livestock. So only 6% is wild mammals anymore. So we've completely, crowded them out. And the same goes for bird diversity. What is of particular concern for the Food and Agricultural Organization of the UN is the fact that 95% of plant genetic diversity has been lost as a consequence of people, only planting the genetically uniform and high-yielding varieties. And this is particularly dangerous because without genetic variation, these crops are highly vulnerable to a disease, a virus, a bacteria that can take it all out. And at this stage, bananas is one of it's very genetically homogeneous and is at the risk of, if a virus comes that attacks banana trees, we might lose bananas out of the food system. So if one now looks at animal-based foods compared to plant-based foods, this is the division here. It's plant-based foods on the left, animal-based foods on the right. I think you can immediately see that the one thing that outperforms everything else for land use, for the use of fresh water, and for the emission of greenhouse gases is beef production. Then you've got dairy, poultry, pork, eggs, and fish here. Okay, so compared to plant-based foods, and they don't have fruits and vegetables here, but I can promise you that also doesn't go, anywhere near the levels that beef production sits at. So one can immediately see here that the footprint of animal foods is far greater, and especially beef, than it is for plant-based foods. If we look at it specifically animal-based foods, the World Resource Research Institution calculated that between 2006 up to 2050, they predict their prediction equations, the global demand for beef will increase by 95% and for animal-based foods by 80%. And this growth is expected to be concentrated in urban areas. And I just want to also add something. By 2050, it's predicted that 2/3 of the world population will be urbanized, will be living in cities. And that's not very long from now. And that would be included or be specifically evident in urban areas of emerging economies like China, Brazil, and India. And you can see South Africa there. When it comes to the the animal-based foods, we seem to be very low per capita compared to the others. But this is the important thing also. We're looking at countries as a whole, and we know as practitioners that there's a very big difference between people of affluence. Animal foods is part of our culture. It's part of the perception of affluence. And then we have people that really cannot afford it, and they actually the ones contributing to this low per capita intake. And so that one has to take that into consideration. Then, interestingly enough, if you look at protein in animal feeds and how much of it, how efficiently it's converted to protein in the food that we actually eat in the end, beef actually also performs very poorly compared to eggs and milk and poultry. So just another way of looking at it. Then the whole change in the environment has other effects on health. So, for instance, increasing the incidence of infectious food and waterborne pathogens, increasing aflatoxin contamination. I'm not even going to go through all of it. Concentrating toxic heavy metals in the ground that then gets into our staple crops, and then pesticides and chemical residue contamination, because we are highly, our agricultural system, reliant on these things now. And then we also have the considerations of hormone and antibiotics that need to be very well regulated to make sure that it does not affect human health. So to put that all together, while the Green Revolution gave us a massive increase in the production of staple cereals, it also, the unintended consequence was that with all these cheap cereal in the food system, it just became the next thing for the food industry to do to make a lot of the high energy, nutrient deficient processed foods that we know these days, because they've got long shelf lives, they cheaper to produce, they highly palatable, so we lap it up. So that is unfortunately became one of the unintended consequences, and the significant link to the global obesity crisis and NCDs is not something that I need to lecture you guys on. However, on the other hand, this focus on staple foods at the expense of dietary diversity is a key driver of micronutrient malnutrition globally. So how they addressed it initially, and still doing that, is by micronutrient fortification of the staples. But what we are realizing in the last few decades is that there's something else called the food matrix, and that the way that micronutrients act within something where you added it back compared to where it's naturally is very different. And you can read up maybe about the dairy matrix to explain that. I think Prof. Walsh will say something about that this afternoon. So, in our food system, we've got lots of staple cereals and all the other things made from them, and a reduced availability of the vegetables, fruits, pulses, nuts, and seeds that we actually need. Another point is per capita food security does not mean universal household food security. And in this country, 1 in 5 households at least is food insecure. And in some areas, of course, this is now over the whole country. In some areas, this is much higher than in others. Another very interesting fact for me was that biologists estimate that in the Paleolithic times, the hunter-gatherers had access to 200,000 to 300,000 different types of edible plants on this planet. Modern man, in our modern food system, 75% of the world's food is derived from a mere 12 plants and 5 animal species. So that in the end is, if you read up about it, is one of the ways how we got, to the point where we don't have omega-3 in our diets. We have to, go look for it in fish. It's not in the plant-based diet anymore. And then, of course, you know that we sit with the triple burden of malnutrition and the NCD pandemic, which was never the intention of the revolution. Talking about the NCDs, if we look at the contribution of diet to global premature deaths due to its NCDs, we see that, yes, obesity, a big driver of NCDs. But if you look at the different foods, it's very interesting to see that the biggest driver of NCDs is diets low in fruits, low in whole grains and low in vegetables, compared to high sugary drinks here. So we tend to also focus sometimes on the wrong things. So globally, the drivers of this is rising incomes, urbanization, changing consumer preferences. It's a complicated business. But in the end, the sum total is we have high availability, accessibility, and affordability of high energy, low nutrient foods. And here we can maybe also see it. This was 2016 dietary intakes versus the reference dietary intakes. So this is the reference dietary intakes, the 100% of the RDA. And you'll see that the whole world is over the limit for red meat, except for South Asia. And then South Africa, or Africa, Sub-Saharan Africa is the blue line. We just make it. And that, again, is we don't see the whole picture. It's because lots of people don't have access, but the affluent people have, eat far too much red meat compared to what we need. And then we can look at it here, maybe at fruits, and you'll see that the whole world is under for fruits, legumes, whole grains, and nuts. And total dairy, which Prof. Walsh will talk about, is also low in most countries in the world. Okay, so we really rely on the red meats and the starchy vegetables. You might recognize this. This is Barry Popkin's patterns, the different patterns of eating, 5 different patterns of nutrition transition, starting from the hunter-gatherer, and we now basically in the whole world, and especially in South Africa, stuck in pattern 4, where we have the rise then of the NCDs compared to the diet that we just discussed. And as dietitians and nutritionists, our focus should be to drive towards pattern 5, which is then the recommended diet, reduction of body weight, and the reduction of the NCDs. Okay. We cannot talk about this whole issue of sustainability without talking about the extent of food waste globally. So globally, 1.3 billion tons, go write that out in zeros and you'll appreciate it, of food that is produced to be eaten is lost every year. So that's 1/3 of the food produced for human consumption, and 1 in every 4 food calories that is produced for us to use never gets eaten by or consumed by humans. So this shows the different countries. You'll see it's much higher in the global north than in the south, but we are sort of somewhere in the middle. And for reasons that I haven't looked up, we are actually predicted to have some of the biggest increase in waste production by 2050. If we look at food waste per capita, so half the food is wasted post-production, up to producing it and post-production before processing it, and then the other half in the rest of the food system. But if we just look at the consumer level, you'll see that South Africa lies down here. So this is the per capita loss of food. We're still, per capita lower than the United States and China, but it is disconcerting. I'll show you the report just now. But to produce food that is never eaten produces 8 to 10% of global greenhouse gas emissions. It uses about 1/3 of the world's agricultural land area and uses 25% of global fresh water, which we cannot, afford anymore. So if we look at what type of foods, we'll see cereals, roots, fruits, and vegetables is most of what is thrown away, those things that we need. Interestingly enough, although low-income groups have lower total food waste, it makes up a much higher proportion of their waste due to improper refrigeration, which is somewhere where we can also talk. Just something to note that overconsumption of food is also a factor that contributes to food waste, although it's not even included in the calculations, and that if we do go to a plant-based diet, it does produce more food waste, but it's still outweighed by all the other problems. So what now? So we've got hundreds of different organizations working in this space. The United Nations in 2015 coined the Sustainable Development Goals. Goals 2, 12, and 3 are basically the ones that we're focusing on here. And with this coining of the goals, they realized that it's all a system. And they produced only in 2017, that to me was a surprise, they came up with this conceptual framework that marries the food system, so that's the food supply system, with health. So what are the drivers of it? And the most important component of this is maybe displacement of the food environment between the two, between where food comes to the consumer and where consumers makes decision that drives their diets. Okay, so we've talked about this before, so I'm not going to say much about it. The Eat Lancet Commission, worked out. They did a mathematical model to see what will we have to do by 2050 to feed 10 billion people. And most of the things that you've actually saw there already came out in this report. And what I really wanted to say, I'm not going to go into it, is that the British Dietetics Association, the American Academy of Nutrition and Dietetics, the Dietetic Association of Australia, and the Association Dietetics of Canada has all come out with position statements on sustainability and what our role as dietitians are in it. And there's also, slowly but surely, coming out articles. So I predict that we'll be seeing it in our textbooks soon. The evidence-based healthy practices are the things that you can probably list for me as well. I'm not going to go through that, but talking about the role of the dietitian or nutritionist, if we look at the food system, the production, storage, transformation, and transportation of food, that's not within our direct influence, but we surely have advocacy over that. When it comes to the food system, the food environment within the food system, that's really the interface between the food system and the diet, what people decide to eat. There we've got more agency about the external domain, that is the way that food is made available, what it costs, the vendor product properties, how it's regulated. We certainly have agency over that, but the place where that we have the most direct impact is when we work with our clients in their personal domain. Thinking about how accessible is the food that's available for them. Things like the cost of transport, what transport they have, how affordable is it for them. In this convenience space, how much time, how much equipment do they actually have to make this food? And in the desirability space, what knowledge and skills do they have to do it? What role does their culture and the tastes and desires, the things that they are used to, play in it? So this is a very useful model to actually unpack these things for us. In the research space, there's definitely the dietary guidelines. So there's a drive for dietary guidelines across the world to also include sustainability. And Qatar, Germany, Sweden, and Brazil are the only 4 countries that has done it so far. But these are the things that are coming our way. The barriers to sustainable diets that we can certainly do something about using our agency and our knowledge and our skills, our behavioral change models, is awareness, affordability, food culture, convenience, and lack of skills. So this is what the BDA takes from it. So in conclusion, the Academy of Nutrition and Dietetics and Dietitians of Canada, both in these closing summaries, say that dietitians are well positioned but under-leveraged and because of our space in the food system, to actually make a difference here. So I think it's important that we start thinking about these things in the bigger picture. And then what I see here is a unique gap for South Africa to take the lead on establishing how sustainability should be incorporated into nutrition practices, guidelines, and policies in sub-Saharan Africa, because our drivers of the impact on the food system, on the environment, is very different in certain senses than that of the high-income countries. Thank you.
Thank you, Prof. van der Berg. Do we have any questions for her while she is here? Yes, Carl.
Being from the food system side, the production side, is going to ask a question that I won't know the answer for, but let me see.
So maybe I should specify that the foundation is a separate organization, so I can't speak for my colleagues in food production. And Tiger is actually more in food processing than in food production and manufacture. So my particular interest, Prof, is there are two major areas in sustainability. The one is the environmental issues, which you've elucidated on very nicely. The other, of course, is inequality, because we have to fix that part of society in order for us to fix the environmental part of society, because in an unequal society, and you touched on it in terms of vulnerable families' purchasing habits and cooking habits around processed food, we can't, they have to talk to each other. So as an organization, we've started to talk about environmental factors within the foundation, which is a first for us. So we do things like, carbon footprint calculations, and we're looking at recycling and composting initiatives with waste food. But I would be very curious in the realm of nutrition, and perhaps there's a question also for the room. What are dietitians doing in terms of dealing with the inequality aspect of sustainability, as opposed to kind of the science and the environmental aspect of sustainability?
This is why I say I see this unique opportunity for us, because it is something that we will have to interpret. It's very different, the lens that we look at it. The textbook that we use in the module on sustainable food systems, starts out with the 3 pillars. The 3 pillars actually is sustainable, environmental sustainability, nutrition sustainability, so the fight against malnutrition, and then equality and equity. So this is exactly what I mean with using that food environment model. It's very easy, like you said in the beginning, to talk and, you see the solutions, but you're not in that person's shoes. So using that personal domain of the food environment to think, these guidelines that I'm giving, that are based on all the research and the things that are done in high-income countries, but how doable is it for you? So is it accessible? How accessible are these things for you? How affordable is it for you? How does it fit into your lifestyle in terms of, how convenient? Convenient now sounds lazy, but it's not what it is. If a mother has to get up at 4 o'clock in the morning to get the bus or the taxi, to be at work at 7 o'clock in the morning before, maybe she's a cleaner, before the people go to work, and then, only go back tonight, get home at 5, 6 o'clock, what happens to her kids and her family in that? That is the point about convenience, so that also. Then the fact, what equipment do people have? We saw that lack of refrigeration is one of the biggest issues. So what can we do in that space? And that's where we can personally address equity. If people don't have it, it's not in my power to give everybody a refrigerator, but I could, guide them, teach them on food preservation, because these sort of skills are also things that are actually disappearing, the skill to be able to preserve, things like that. So that's exactly what I mean with, our lens should be a lens of equity. And equity is about not everybody starting from the same starting point. And that inequity in the system leads to inequalities of malnutrition. Why some people have got enough food, but some people are malnourished. And to be, cognizant of that. So I think on the ground level, that is where we need to have influence, first of all. And then there's advocacy spaces and, other places we also need to voice, and research spaces. But I think for this room, that would be my answer.
Sorry, Khanso, can you maybe just wait for the microphone so our online delegates can hear your question? It sounds important.
Yeah, I was just saying the question that he's raising is actually quite relevant for this platform, for the South African population as a whole, because we are seeing that as students, we are taught about socio-economic conditions. But when we get to the ground level or we start counseling our patients, those are the factors that we don't really look into. And as dietitians, we have to understand that it's not a matter of one size fits all. Some people are really impoverished out there. But when we counsel them and when we visit them, we need to make sure that we leave them with something. We need to teach them how to fish instead of always giving them the answers. Hence, with community nutrition, we try and also give them seeds so that they can have food gardens, you know. And like you're saying, some of the issues like refrigerator and things like that, they do know how to keep their food cold and so forth. They'll have like a cold room or a cold corner somewhere in the house. It's just that us as dietitians also, we need to go out there and find out how are they surviving in order to be able to help them better, you know.
It comes back to the right to food. Is the human right to food is actually the right to feed yourself with dignity, you know, which is exactly what you're saying. Thank you.
Any questions online, Ina? All right. Thank you very much, Prof. van der Berg. It's very interesting. Whenever she speaks about food sustainability, she started giving this class this year on food sustainability. And the more she teaches about it, the more passionate she is about it. I sometimes feel like I wish I was a first year and I could go sit in her class again. So maybe a tip, if you're ever bored and on a Thursday, Prof. van der Berg's food sustainability class is there to fill your time. All right, next we have Mrs. Space. So Mrs. Admi Space is from the Department of Nutrition and Dietetics. She is currently pursuing her PhD and is recognized for her interest in medical nutrition therapy for critically ill patients. With extensive experience and a deep commitment to improving patient outcomes, Mrs. Spies has dedicated her career to understanding the complexities of nutrition in the critical care settings. Her expertise in this area has made significant contributions to the field, helping to advance the standards of care for critically ill patients. Today, she will be exploring the practicalities of the indirect calorimetry, a crucial tool in assessing and meeting the nutritional needs of patients in the ICU. Her insights will provide us with a deeper understanding on how to effectively implement this technique in the clinical practice. Please welcome her to the stage.
Morning from my side as well. I know you already feel very welcome. So I'm going to talk about the practicalities of indirect calorimetry. So accurate energy measurements in the ICU have many benefits. If you estimate the energy correctly and you provide the correct energy for your ICU patient, the benefits will be they will be weaned off the ventilator faster, less complications, shorter length of stay, reduced mortality, and lower rates of rehab facility discharge, meaning that your patients can resume their normal activities of daily living faster. So today we're going to talk about how does it work. If you don't have a calorimetry device, the use of predictive equations, factors that could influence energy needs like muscle mass, activity, and medication. We're going to talk about just something interesting and some background. What's the difference between resting energy expenditure, total energy expenditure and basal energy expenditure, and describing the actual calorimetry procedure. Just some few tips on that. So according to ESPEN and ASPEN, indirect calorimetry is the gold standard for measuring energy needs. But as we know in South Africa, we don't use it often because of the cost, and it's not often available. So determining energy needs with calorimetry is independent of body measurements, age, and biological sex, as in the case of predictive equations. So how does calorimetry work? The device uses inspired oxygen and expired CO2, and also using the respiratory quotient and the equation, determining what's the patient's energy needs. So as you can see, no age is needed, no height or body weight is needed, no gender is needed. It's independent. Okay, so if you don't have a calorimetry device, then we all use predictive equations. So in an Israeli study of 1,440 ICU patients, none of the 8 predictive equations had showed more than 50% agreement. And the agreement was defined as if the prediction were in the range of 85 to 115% of REE measured by the device. The Harris-Benedict was the closest, using a correction factor of 1.3, but it was still not within 50% agreement. So what that means is that if you use predictive equations, half of the time, the energy that you estimate will be incorrect. And there you can see that nice sweet spot that we want. Any predictive equation that gives you a value close to 85% to 150% of the calorimetry device measurement, that's what you want. But half of the time, the predictive equations doesn't give you that value. So calorimetry, another study in the United States amongst 419 ICU patients, they used the predictive equation of 25 kilocalories per kilogram, and that only showed a 34% agreement. So that equation, 1 out of 3 times, it was correct. So the issue with predictive equations is it does not consider the dynamic metabolic changes over time. Your patient can be having sepsis or other changes. It doesn't take that into account. And then also the predictive equations are very inaccurate for obese patients, very low body weight patients, and then also patients that have severe disease states. The other thing with predictive equations, specifically in the ICU, is we struggle to estimate height. So from our own researchers, Prof. van der Berg and Hannah, the research that they've done has shown that usually in the ICU, we estimate height with the ulnar length. But actually what they've shown is that in South Africa, height is better estimated with knee height. And then it's also an estimation that you put in the predictive equation. It's not the real height of the patient. You actually estimate it, and even though knee height's more accurate, it's still a variable, it's still an estimation. If we look at low muscle mass and energy, reduced muscle mass decrease resting energy expenditure. And in critical illness, where 4 or more organs failed, it resulted in more than 15% muscle loss after day 7 in the ICU. So your predictive equation will not also take that muscle mass into account, muscle mass loss. So how can we try and incorporate possibly in future low muscle mass? Is you can use a multi-frequency bioelectrical impedance analysis with a body composition analyzer. The problem with with these devices, even though we can use it for bedridden patients, is that you still need to enter a height and a weight for some of the values, to get some of the values. But in ICU, you can use the phase angle that you get from the MFBIA device, which is a true value. It doesn't require estimations from other variables. So if you look at the phase angle, if your phase angle is below 5 in males and below 4.6 in women, that can possibly show that your ICU patient is malnourished. So that is just also something in future that we need to consider, is the energy, or we're not maybe possibly overfeeding our patient because of low muscle mass. The other thing that will influence energy needs is activity, and that's also something interesting to determine in the ICU. So you can use the ICU mobility scale, the IMS. So this is a scale with a scoring of 0 to 10. So I know in our predictive equations, we usually, for activity factor, we use 1.1, patient lying in bed. But actually, for ICU, certain activities could actually influence the patient's energy needs more than what we know of. So if you look at score 3, sitting over the edge of the bed, you're actually more active than score 0. Or score 7, walking with assistance of 2 or more people. If you're in the ICU and you're doing that, that could possibly influence your energy needs as well. So this is what I've found about this score. It's nice and easy. There's a nice definition that, and anybody or a dietitian can use this to sort of see, okay, what's the activity levels of my ICU patient. The effect of medications on energy. So central nervous system agents like propofol, narcotics, morphine, all of them can decrease the metabolic rate. Propofol can decrease the energy needs by 18%, and your narcotics can decrease the energy of your patient by 33%. And as we know, our predictive equation doesn't take into account the medication that the patient is actually consuming. Also, your neuromuscular blocking agents also can have a possible 33% decrease in resting energy expenditure. And then also your beta blockers can also have a 12% decrease in resting energy expenditure. So just to continue on and look at this interesting aspect of energy, resting energy expenditure and total energy expenditure. So in the ICU, measured resting energy expenditure should be considered as total energy expenditure. So as we know, the calorimetry device measures resting energy expenditure, but in the ICU, that value that you get from the device, you don't have to add a stress factor or an activity factor. That can be considered as total energy. And then obviously this statement must be revised if physical activity becomes a standard routine in ICU care. Then you probably will have to add an activity factor. So what's the difference between resting energy expenditure and basal energy expenditure? So basal energy expenditure requires precise conditions. You need 8 hours of sleep followed by 12 hours of fasting. Then you need to be seated in a recumbent position with minimal interruptions. And if you take that measurement, that is basal energy expenditure. So because of the rigorous measurement requirements of basal energy expenditure, the actual measurement is not practical in most clinical settings. However, resting energy expenditure is within 10% of basal energy expenditure, and that's why you can use resting energy expenditure in clinical settings instead of using BEE. So if we look at the procedure, the prerequisites for calorimetry, if your patient is on a ventilator, the FiO2 should be below 60 or 70%. Your PEEP should be below 12. Your patient should have a stable pH, so they need to be hemodynamically stable. They need to have a stable body temperature for at least an hour before the procedure. And you can perform calorimetry for mechanically ventilated patients or if they are spontaneously breathing, but you can't use it if the patient is having non-invasive ventilation or high-flow oxygen therapy. So the preparation before you perform the procedure, the room temperature needs to be mild. Patient should be comfortable. Prior to the measurement, they shouldn't have any, for an hour before the measurement, they shouldn't have undergone any physio or washing. The device needs to be warmed up. The device needs to be calibrated. You need to make sure that there's a filter. So there's quite a few things that you need to check just to make sure that you get the most accurate energy measurement. During the measurement, no physical activity, obviously no suctioning, and then you need a steady state of at least 10 minutes while the procedure is being performed, and you need to take that value. Let's say you take the measurement and the patient is not in a steady state, then you need to stop the measurement and do it later in the day or do it the next day. So that's quite important for accurate results. The respiratory quotient needs to be between 0.67 and 1.2. That's also a sort of a measurement of validity. So if your calorimetry measurement, the RQ is outside of this, then you also don't use that measurement. Repeat the measurement later in the day or the next day. So that is also just something that you can check, and that tells you, okay, this measurement was actually valid. So the take-home message is more research on determining energy needs is needed to ensure we provide the most accurate energy to our South African ICU patients. So this is actually an invitation for you to come and do your master study or your PhD, because we are in a unique situation where we have other circumstances than the European or the American ICUs. So we can make a big difference in this space as well. Thank you. Any questions?
Thank you, Armi. There's an online question from Nazreen. She asks, how is the phase angle determined? So what assessment is conducted and how is it conducted?
Okay, so the phase angle, you need a body composition device, like an in-body, but specifically in the ICU, you will need the in-body where you can, or any device, it doesn't have to be the in-body, but where the monitors are connected to the wrists and to the ankles. And then part of the values that you get is phase angle values. So it's part of the values, and that's actually, you can use those values because the other, like muscle mass values, depend on equations where you have to enter height and weight. But the phase angle is independent of weight and height. So you need a body composition device. Does that answer it? So again, the invitation for research, we have that device at the university where we can measure body composition for patients that are recumbent. So you can definitely come.
Armi, I'd like to know from you, Have you done any comparisons to look at the calculated REE with what the indirect calorimetry gives in terms of the energy needs?
Yeah, so that's part of my PhD project, is to look at that and to see, do we get the same results than in Europe and America if we compare our patients' calorimetry values to predictive equations? So that's part of the research that I'm doing. So if I have answers, I'll share it.
But the predictive equations are from overseas, so it's not based on our South African.
Thank you, Armi, for a very interesting session. I just want to say something on the question. The last question is, it's not now on a patient, it was on myself. The indirect calorimetry was done by one of our representatives. And just a week before that, I did my in-body, and my amount of energy, the BEE was exactly the same. So obviously it was only one case, so I'm looking forward to see your results.
Yeah. Muscle mass is very interesting, and we need to look at muscle mass for non-communicable diseases. We need to look at muscle mass in the ICU. We need to look at muscle mass in our children, school-going children. So that's a very important aspect of nutritional status that we need to delve into more. And we need to monitor it. Thank you.
Let's give a round of applause. Thank you very much, Armi. During the lunch break, you are welcome to pick her brain on the medical nutrition therapy of ICU patients. On Thursdays, there is an online ward round for ICU patients that she's involved in, so do be sure to go and pick her brain about that. Next, ladies and gentlemen, it is my distinct pleasure to introduce our esteemed speaker, Ms. Karina Miller, a highly qualified dietitian and educator. For the past 12 years, she's been a pivotal force in the National School Nutrition Program, serving as Chief Education Specialist. In her role with the NSNP, she ensures that over 9 million learners receive a nutritious meal at every school day. Beyond her work with the NSNP, she has extensive experience collaborating with various government departments and stakeholders to tackle broader issues of food security. She actively supports the steering committee of the Department of Planning, monitoring and evaluations of the National Food and Nutrition Security Plan, striving to ensure optimal food security and improve nutritional outcomes for all South Africans. Today, she'll be sharing her valuable insights and experiences. So thank you very much, Karina Miller. Let's welcome her to the stage.
Just quickly.
Good afternoon, everybody. I think I'm the first one to say that for today. Standing here in front, I must say, coming from the education sector, I almost feel to tell everybody come closer because it's what we do in a class environment. But this is not. It's always for me a pleasure to be here at the University of Free State, at your department, and we always learn or take a lot of learnings home. Now today, when I had to think about the presentation, the word dignity stuck in my head because the theme for today is dietetics with dignity, but with the school environment and especially with the National School Nutrition Program, it's nutrition with dignity. And dignity is a really quite a challenging term for us. So today when I'm looking at the presentation, I look at the internal NSNP, the National School Nutrition Program environment, and factors that might influence the dignity, and then also the external school food environment, which we would look at the tuck shops and the vendors, which is quite challenging at school levels. Then, just to give you some background on the National School Nutrition Program, it's a key poverty alleviation program. It gets the most funding from government after the social grants. The NSNP is funded by National Treasury. We call it a conditional grant, and it is ring-fenced. And at the moment, we look at more than 9 billion for the 24-25 financial year. So it's quite a huge responsibility, but what do we do with that funding? We provide meals to 9.5 million learners in over 21,000 schools. So it's a huge program. Then what we do in the NSNP, we try to do a 5-day cycle menu, which consists of a protein, a starch, plus a vegetable and fruit once a week. The vegetables is 4 times, the fruit once. Then we also have committed to phase in a breakfast porridge to improve the energy intake of the learners, but we also look in improving the protein in the program. And I will touch on it in the presentation, but specifically we looked at processed chicken liver. Then currently for the breakfast, just to give you an update, we are very positive and glad that most of our primary schools in the country that's on the program is including breakfast porridge, which is in the form of a maize or sorghum instant porridges that we give. Mpumalanga is still targeting, but we are working in expanding the program there. Then factors that impact on the dignity of the meals provided in the NSNP. Firstly, all provinces need to have an approved menu. With other words, with the protein, with the starch and the vegetable, and once a fruit for a week. Then what will influence the quality of this meal would be the meal preparers, which we call the volunteer food handlers. Then another huge factor that impacts on dignity is the adequate eating utensils. Then quality food items is another huge factor. And then also part of the quality food items is the compliance to the food safety in the value chain. And then if you look at all of these factors, we want to serve a nutritious meal on time. On time is for us an important factor as well, because we normally say before 10, but now that we introduced breakfast, we say before 11:30. Now, the conditional grant framework needs to give us some guidance on quality. And here we say, we again state that there must be a starch, protein, and vegetable or fruit. There must be the breakfast porridge should be incrementally phased in. Then also the fresh fruits and vegetables must be served daily and vary between green, yellow and red. And you know, because you, the experts about the nutrients in the food. Then also a variety of protein-rich foods. Then we've brought in grade 1 and 2 sugar beans. The grading is important. We have challenges when it's not graded, then the food that's delivered to school is in bulk, and then when it's not graded, the volunteer food handlers will cook and cook and cook, and the food won't get soft. So we had to bring that quality in. Then specifically when it comes to soya mince, we also made a change here, where before when soya mince were packaged, we required the soya mince and the seasoning to be mixed together, but they had to align to a food specification. Now, because there were so many poor quality soya that we've seen in schools, we require the soya mince, the granules to be packed separate from the seasoning. So then we can measure how much soya is there and how much seasoning, so that we have better control. Then the other product would be your canned pilchards, mackerel or sardines. It's one of in tomato, which must be served once a week. And then also our UHT milk or pasteurized mass, that also is another protein that must be served. And then we also specify seasoning, otherwise the meals might be very bland. Just this slide I've brought in because the NSNP monthly food basket, when it comes to food security, most of our procurement processes in the provinces differ. We have centralized and decentralized. When it's centralized, we have service providers that buy in bulk. When it's decentralized, we have schools that procure from the local market or supermarkets. And we are currently looking if we can't change the system and make use of our large food basket. Because if you just look at one, for 1 month, the maize that we use is 2,880 tons. And at the moment, we don't get the benefit of it. We cannot discuss with the private sector and say, how can we get it for a reasonable price? I can talk about the whole food basket, but I just make the example of maize. So we are really looking into changing the system because we have such a large quantity of learners that we need to provide the meals for. So we need to make sure that we give the best quality for the best price. Then when we look at the quality, we also have to align with Department of Health, the Foodstuff, Cosmetic and Disinfectant Act. And specifically here, we look at Regulation 638 because it doesn't help if the food is of good quality, but in the end, how does our preparation areas look like? And it's still for us a challenge because some of our schools really make use of classrooms, of storerooms, wherever they can to prepare the meals. So we are training on Regulation 638 about the general hygiene, the food safety, how the food should be transported. And then we also work with local municipalities to see if we can get kitchen compliance. So with the hospital kitchens, all the kitchens need to have a certificate of acceptability, and we are in the process to look if our schools can have the COAs. But then again, you have different provinces. If you go to Limpopo, if you go to Northwest, they still make use of firewood. So there's no compliance. And so in that sense, there's still a lot of work that we need to do. And then the other thing is when we have our big tenders, we really advocate that they transport the food in closed vehicles. Then when we look at our food specifications, this is what regulates the quality as well. We have to align with the South African food-based dietary guidelines. When we look at our menus, we prefer that where we can, we look at locally produced food for the menus. And then we also work with other government departments like DALRA, Department of Health, and then the National Regulation for Compulsory Specifications. That's specifically when it comes to our canned products or the processed products. Then an interesting factor, when we looked at the MASI, when we look at milk, we can see it's pasteurized. But when we look at the MASI, it's not pasteurized. But then we brought into the specification that we say it must state it is made from pasteurized milk. So it's small detail, but it's things that we had to look at to ensure the safety of the learners. Then we have non-perishable foods. We look at the shelf life. We found that often there's service providers that deliver food, then it's almost near to expiry. Then they expect that food to be given to learners. And so we've changed it in our specifications to make the shelf life longer because sometimes the food have to stay over the holidays. So we have to ensure the safety again. Then perishable food, 7 days shelf life. And then when we come to the newest project, the chicken livers, what we've done is we've had to source safety within chicken livers. So we had to come up with a specification and manufacturers to produce for us retort or canned chicken livers or processed chicken livers with a process that we call high pressure processed HPP, and this lengthen the shelf life of the product. So when we talk about processed chicken livers, it's not something that you would generally see on the market, but it's something that we have developed as part of the NSNP because the chicken livers, when we look at the nutritional analysis, that they give us the best nutritional content for the meals of the NSNP. Then another one that was interesting, and here Tiger Brands is also in the room, so I tread carefully. But when it comes to the instant porridges, we found that in South Africa, our instant porridges are not aligned to the World Health Organization specification that it must be about 8 to 10 grams per 100 grams. So we also introduced this into our specification. So we also try to regulate the industry. Then I'm going to touch further on the specifications. When it comes to proteins, I indicated the class 1 and 2. I also talked about the pilchards and the livers. Here it's just interesting. I saw in our packets, we all got beans, white beans. And one of the key things when we started to look at canned or retort products were the drained mass. Because one of the things that we've realized, the moment that price hikes go up, or that, for instance, there was a time that the manufacturers struggled to get pilchards, then what they would do, they would say, for instance, where we were used to a 425 grams can, it's suddenly 410, but the price doesn't go down, but there's less in the content. So we also had to specify and had to look, even for drained mass, that the quality in that can is still relevant. Then we also use UHT milk. UHT milk is more expensive than fresh milk, but it is safe. Storage conditions, especially when we talk about large quantities, we had to consider what would be food safe, and the UHT milk is the safest product. I've talked about the Marcy, then the soya. I indicated about the separate packaging, that spices must be packed separately, and then the soya in 25 kilogram bag must have 1.25 Ks or 5% of spices. So you can see we really regulate that the spicing is much less than we had it in the past. And then also the cooking instructions is also another factor, because with the cooking, people can make, well, when I started to work in the NSNP, they did not talk about soya mince, they talk about the soup. Now, the soup was our soya, and that was supposed to be a protein. So that's why we regulated the soya, and then we also have to regulate the cooking instructions so that they don't make it too thin. We want to see a mince-like consistency and not a soup. Then the starches, fruits and vegetables. Here we talked about that maize, brown bread, wheat flour and bread should be fortified. Rice, we specify parboiled long grain. And then I spoke about the instant porridges and the sugar content, and then the fruits and vegetables. Fruit and vegetables is a sad story within the program, because we look at the quality. It's not always the best quality. I've seen apples that looks like this, that they deliver to the children. So there's still a lot of work, and we as the NSNP do monitor. We have a standard monitoring system across provinces, but you can imagine 21,000 schools is a lot, so we can't get to them weekly. We normally get to a school once a term. Then our volunteer food handlers, we have more than 60,000 food handlers that prepare, cook and serve meals to the learners. And what we can do, we appoint them for a 2-year rotational period. We cannot appoint them permanent. We simply don't have the funding, so we indicate that we give them a stipend. The stipend is in line with the expanded public works program, their rates. Then what we do provide for the volunteer food handlers is the stipend and then UIF, Unemployment Insurance Fund, and then personal protective equipment, and the minimum guide that we must give is an apron, headgear, and safety shoes. And then, of course, training of the volunteer food handlers. The next slide, I also look at Tiger Brands Foundation a bit here because I give credit to them. The NSNP doesn't always have the funding for research, so we depend on our partners. And I've taken liberty to talk about a report from Tiger Brands that's not yet published, but they have done research on volunteer food handler training and the impact thereof. So although we want to train them regularly, you can imagine every 2 years we have a new cohort, and to train them we sometimes lag behind. So we depend on partners, but what a proper, decent training has done for the volunteer food handlers, where Tiger Brands have introduced a unit standard-based training. Some of the findings that we got, where they say the children liked the way the food tasted after the training. They asked for more. Always positive to hear that. The trained volunteer food handlers share their skills with the new ones. That's also good for us. And then also the volunteer food handlers knows much better to prepare the food and address children compared to those not trained. And then lastly, the certificate, because Tiger Brands give them a certificate, is proof that I know about food and food hygiene. It really lifts them up as well. And Tiger Brands has gone as far as to do a certification ceremony, and it's the first time that some of these, it's mostly ladies, mamas from the community, attend these types of functions, and it really lifts their image. And for us, it's such a positive to introduce something like that to the volunteer food handlers. Then I'm coming more now to the external environment, the complexity in the school food environment. The regulation of tuck shops and vendors at school level are really challenging, because most of our challenges is in the sugar beverages that they give, the crisps, all of the high salt, high sugar items that you